Okay, thanks. Good morning, everybody. First of all, welcome to the first meeting of 2022 of this key health committee in Gloucestershire. You're all very welcome. So it's going to be challenging for me to try and chair a meeting remotely. So if I don't notice your hand is up, or I don't notice you frantically waving in my screen, somehow can you I don't know what else there is left to us to try and get things moving, but somehow we'll get through this. But just very genuine, obviously, thank you to all of our health colleagues who, during this crazy time for them, still find time to compile very complicated reports, set them out extremely well, and most importantly of all, get them to us in good time. On top of the day job, everybody, I so appreciate what you're doing to help us as elected members across Gloucestershire. Thank you so much. So those are my opening remarks. Going to the agenda, Joe, help me out if I'm wrong, but we have no apologies from elected members. Is that correct?
That is correct. No apologies from elected members,
okay.
Andrew.
Then we have an apology from Mary Hutton, and she's represented this morning by Mark Walkinshaw, amongst others. So welcome, Mark. And Dr. Mark Poltroni, Gloucestershire NHS Foundation Hospitals Trust, obviously, is represented by Simon Lansley. So good morning to you too. So as you were mentioning, Joe, just before we went live, it's a really good opportunity to welcome Dame Jill Morgan, the Chair Designate of the Gloucestershire Integrated Care Board. Boy, that's a bit of a mouthful there. But Dame Jill, you're very, very welcome. And Helen Goody, good to welcome you, Director of Primary Care at the CCG. Mark Walkinshaw. And there was a late message last night, I think, Joe, from you saying that Dino Motti, I hope I pronounced that correctly, is dialing in. He's a new consultant in public health.
Yes, that's correct.
So everybody, you're all very welcome, particularly members who haven't been to HOSC before. So thank you for that. So item 4, we've received no public representations. Item 5, primary care slideshow presentation.
Oh, Andrew, we need to just go through declarations of interest and confirm the minutes of the last meeting.
Okay, I was just working from your agenda here, or somebody's agenda. Sorry. Okay, sorry, I apologise. Any declarations of interest? I take that as none. And what was the other one, Joe? Just remind me.
Just to confirm the minutes of the meeting on the 30th of November.
Okay, thank you for that. I will find the original agenda. So everybody happy I sign those as a true record, please? Any amendments required, omissions, corrections? No. If people like to raise their hand, whatever, that's probably all you can do on virtual meetings. Yeah, okay, that's good enough for me. We've got a proposer and a seconder.
Lovely.
And then hopefully, Joe, please keep interrupting me when I skip things and miss things. Thank you so much for that. That's valuable help to me. So we do now hopefully go on to item 5,
Perfect.
which is the primary care slideshow presentation by Helen Goody and Andy Seymour, Dr. Andy Seymour. Just as with all of these presentations that we got this morning, can we all assume, please, that everybody has had them in good time, which they have, and also read them, and just can we leave it to the professionals to introduce the report with just 3 or 4 very, very key bullet points that they want us to grasp, and then we'll open it up to questions and comments. Is that okay? Hopefully everybody's happy with that. And just repeat, I'm so pleased that you're able to get us these reports in good time. That makes our lives so much easier. So Andy, Dr. Seymour, over to you, and Helen. Thank you.
Thank you very much, Chair, and well, good morning, everyone. So I'm going to hand over to Helen shortly, but as you'll recall from a couple of HOSs ago, there were 1 or 2 questions being asked about access to primary care and primary care issues. So I thought it was probably timely for us to present a whole section on primary care. And as Chair has said, we've sent a fuller presentation through, which I hope you've had a chance to look at. But what Helen's going to take you through is an abbreviated, more punchy presentation, concentrating on the issues really of importance. And one of the key messages we want to get across is not only that primary care is very efficient and working hard in themselves, but they're working as a key part of the system, and that's really kind of a main message that we want to get across today. So I'm just going to hand over to Helen now. Thank you.
Thank you, Andy. Thank you, Chair. If I just introduce myself, my name is Helen Gooding. I'm the Director of Primary Care and Locality Development. I'm a Joint Director with the CCG and Gloucestershire Health and Care Trust. So thank you for giving me the opportunity. I will be punchy and I will be as succinct as I possibly can, Chair. Next slide, please. So just to set the scene, obviously it's been a very challenging couple of years for all health partners, and primary care are no different. For the last 12 months, they have tried to offer urgent care appointments to their patients. They have tried to prioritise chronic disease management, getting the backlog through as much as they possibly can. And they've been also focusing on the areas such as learning disability, health checks, ethnicity, and really sort of the prioritisation of care has been quite challenging for general practice, in line with all other health partners. But they have been open and trying their best to see their patients that need to see them. Next slide, please. I wanted to just touch on the challenges. You'll be aware that morale has been pretty low in general practice. And although that they have made every effort to be open and available for patients, there's been quite a lot of press that has been quite a demoralising impact on general practice. And I'm seeing more and more GPs that are actually off sick with stress and burnout, similar to other partners in health. However, we are supporting them as much as we possibly can. And I think it's really important that we rebase and reprioritise the relationship, the important relationship between the patients and their GP practice. I know that patients have been very frustrated through this time. I think it's been reflected in the relationship between the receptionists, the clinicians and the patients. And our priority really is to get that relationship back on track and see how we can support and help, because GPs and their staff are there in the community because they want to work with their patients in that advocate close way. Next slide, please. So this slide really isn't just a pretty picture. What I really wanted to remind everybody is that we used to have 86 GP practices. We now currently have 71. That's not through losing practices. It's just the reconfiguration of general practice in Gloucestershire. We've now got 15 primary care networks whereby the GPs are now working far more in partnership together. And I have to say, through the last 2 years, that has had the most positive impact on primary care and being able to meet the demands of COVID and certainly the vaccination programme. But equally, the PCNs and the clinical directors are now working with wider partners through the integrated locality partnerships. And we need to really recognise the value of those partnerships, particularly the volunteering sector, because they have had such an impact through the COVID vaccination programme. But we also recognise that if general practice is going to support the wider determinants of health, they need to be around the table with our other partners, and that's the integrated locality partnerships. I hopefully will be able to come back at another point and be able to present on the progress that's being made. But for now, I'll leave it there. Next slide, please. This is probably one of the most contentious issues in general practice, and it's always about access. Access is variable, and I'm not going to sit here and say we've got perfect access in Gloucestershire. I think we have pockets of really, really good access. And when you actually look at our presentation, you can see that we are comparing higher than the national average with our results at 88%. But we also know that there is huge disparity between the highest and the lowest achievers in terms of access. We also know that the survey is not perfect and doesn't always reflect true access on the ground, but it's one of the biggest priorities for Andy and myself as we move through the next 12 months to understand what is driving the variation in access. And if that's workforce, which I'll touch in a moment about, then I think that we need to understand where we can actually make the most impact to improve access and support general practice. But we should be proud of the achievements that we are still higher than national average and certainly the South West as well. Thank you. Next slide, please. The other thing I want to say to you is there's been a lot of news saying that GPs have been closed or they haven't actually been seeing patients. And apart from being hugely demoralising for me and for themselves and the team, I wanted to show you this slide because I think it's really important. We've been looking at access. And we actually did a survey in terms of comparing the same period, June to November 2021, and comparing it with 2019. And GP practices have seen over 11% more appointments, face-to-face, home visits and telephone when compared to that same period. And actually, when you look at November as an exact month, that was 22,000 more appointments than that pre-COVID period. And the slides show there the face-to-face appointments. We are higher than the national average, but we recognise that things have changed. And I'll talk about that in the next slide, please. So things have changed. When COVID hit, I can honestly say we were not embracing the digital agenda. We have far more offers for patients to access appointments from their GP practice using the digital platform. We've got 2 that are available, and there's about 60,000 requests into general practice a month. And 40,000 of those may require a GP, but many of them do not. And the feedback that we're getting from patients, and not all patients, I have to say, is that some patients prefer this quick ability to send an email to their practice and then get a response, and hopefully avoid sitting in a waiting room and taking time out of their day. However, we also recognise that digital is not going to be appropriate for everybody, but it is certainly filling a gap, and I think it's here to stay. And what we need to do is make sure that platforms are far more friendly to use and easily accessible. So that's the things that we need to do over the next 12 months. Next slide, please. I just wanted to say, as we come out of this next phase of COVID, we do know that there's going to be huge demand for elective care. And I think the bonus for Gloucestershire is that we are ahead of the game. Through the technology of G-Care, which is a website based at GP practices, we have the ability that practices and GPs can use G-Care to access consistent pathways into the elective care. These are based on best practice, and you'll be aware that Deb Lee leads the clinical programs. They develop the pathways using best practice and clinical leadership, goes on to G-Care, so that when a patient goes to any one of those 71 practices, they have the ability to have a consistent pathway. And hopefully what we really want to try and achieve is avoid using secondary care services where it's not appropriate and where they can be kept safe and cared for within general practice. So that leads me to my next slide, which is more about the advice and guidance. Again, we need to make sure that we're supporting our secondary care colleagues by making sure that we are managing patients appropriately in primary care. We have now got 19 specialties available on advice and guidance, and this allows the GPs to communicate with secondary care consultants, ask questions about whether this patient should be referred for elective care, or whether their care can be managed in that sort of joint approach between secondary and primary care. We are one of the top users nationally, and I think it's a credit to the system that has developed this, and it's certainly something that we get positive feedback from all system partners. Next slide, please. What we've developed on the success of advice and guidance is partners within secondary care, community and primary care have developed the urgent care offer called Synapsis. This is more important than ever to keep patients away from ED that do not need to be there. So we're having a number of specialties on Synapsis, and we have fantastic feedback in terms of how reactive and responsive they are. GP can ring the consultant at Synapsis, talk about whether a patient should be emergency sent to ED, or whether they can actually go to an assessment unit, or whether they can actually be managed at home within primary care with the support of rapid response and community. I cannot emphasize the importance of these digital solutions that keep our partners working together and support our patients. Next slide, please. So I'm going to focus on the thing that has driven us the last 2 years, and that is the vaccination programme. I think I'd like to remind people that back in December, we were given the, can I take the next slide, please? We were given the challenge of bringing forward the booster vaccination for all eligible over 18s by the end of December. And I'm very proud to say that we have achieved that ambition, and we have actually performed extremely highly in Gloucestershire when compared to the national and southwest region perspective. If I can take the next slide, it will actually show you the performance, and the headline figure is that over 86% of all over 18s that are eligible for a booster, and when I say eligible, it's more in terms of the distance from their second vaccine or whether they've actually had COVID. So eligibility, we've got over 86%. And I think if you actually look at the 1 to 12, the cohorts 1 to 12, which is the over 18s, that's 90% have had a first dose. And cohorts 1 to 16, which is the 12 to 15-year-olds upwards, is 88.4%. So we haven't just been focusing on the booster campaign, although that's been one of the priorities. We have had many, many more come forward for a first vaccine or a second vaccine, and asking lots and lots of questions about vaccination as well, and focusing on pregnant ladies as well. So we are proud, and I think we've got a right to be proud, because we've really pulled out all the stops to get our vaccination programme the best it possibly can be. Next slide, please. Just to say, the map just showed we did take a different approach in Gloucestershire. We didn't have a mass vaccination site. What we did is we put sites close to where people live, and we try to make it as accessible as possible. And I think that's one of the things that we should be really proud of. Next slide, please. I want to just raise the importance of partnership. What we really want to take forward as we come out of COVID is what we've learned by getting our partners working together, whether it's sharing space, whether it's the equity vaccine group that Paul Roberts chaired, which was more about not looking at hard to reach populations, but how our services are hard to reach, and getting into communities, mosques, homeless sites, friendship cafes, and offering vaccinations at that point. And I'd like to say that from that great work, we're now going out to other community settings and offering health checks in places where people go to rather than a health setting. So I think the work that we've learned from the COVID vaccinations is that partnerships are absolutely paramount, and we need to build on that going forward. Next slide, please. I won't take the next slide because I know we're close for time. I would like to finish on slide 18, which is the picture of the GP premises. Thank you. I would like to just, as I'm here to talk about primary care, I would like to emphasise the achievements that have been made in terms of the premises. I think that we have built so many GP practices. I'm hoping that all members will recognise a building that's actually in their vicinity. Over £63 million has been invested. I think it's fair to say that we've got far more now being opened in the next 12 months. We've got the new one in Cheltenham on Prestbury Park. We've got another one in Stroud Town Centre. We're working with Forest of Dean, the Colford and Lydney, and we're also working in South Cotswolds. I think that premises do not just make a nice place to work. They're absolutely paramount for patient care, bringing services out to the community, and really taking the opportunity for partnership working. So thank you, Chair, for giving me the opportunity to run through those slides and give my context, and I'll stop there.
Wow, that was absolutely amazing. Thank you so much for all of the information that was crammed in there. Thank you so much too for making it totally jargon free. Thank you for the good examples of our own local practices. Good to see mine there. Just before we move on, however, I should have welcomed the people who watch these meetings on YouTube. I know that there are several members of different organisations in Gloucestershire who tune in, so I apologise for missing all of you, and welcome to you guys. Well, I really don't know where to start, Helen and Andy, but I'm going to start by letting you take a breath and invite members to ask questions or make any comments, please. Who's going to go first, please? David, Drew, then Stephen Andrews. Thank you.
Thank you, Andrew, and thank you, Andy and Helen. I mean, you may not be able to answer this now, but it'd be useful to have the information. I mean, a lot of my GP friends were in their 50s and 60s, and as far as I know, most of them have gone to retirement and other things. I just would be interested to know what the age profile is in Gloucestershire and GPs now, and also what the makeup is. I mean, clearly, most of those GPs were part owners of the practice. So have we seen a marked shift towards salary GPs, and indeed, you know, number of locums? Because I know my own practice that, you know, it was a 4-doctor practice, it's down to 2, and they have to backfill with locums.
Yes,
Okay.
I'll start, and Helen may be able to add in. We have got the data. Helen might be pulling it up in front of her right now, but and we monitor on a regular basis what we call the whole time equivalent headcount, and also whether they're full time and whether they're salaried and not. So we've got that data, and we've also shown over the last few years. I mean, we probably should have said that as a CCG, we've had what's called delegated commissioning powers for primary care for a number of years, and we were a first wave delegated CCG, so that meant we got involved early to get at the core of managing and overseeing primary care. And we've done a lot of work in the county, advertising for GPs and getting GPs in the county. And our headcount over the last few years has certainly been better than the national average and been higher than national average. But you're right to point out there is a burning platform in terms of age profile of GPs in line with the rest of the country. And as you say, a lot of GPs are retiring. Traditionally, they used to retire at 60. Some are going late 50s now. And this, I would also add, this is an issue for us in terms of practice nurses as well, where we have a high number of staff in the 50s. That said, we do have younger GPs coming through and joining practices. And the last year or so, we've been very encouraged that a number of practices have been successful in recruiting young GPs. So we are fairly confident that going forward that we'll have some sustainability from that perspective. Don't know if you want to add anything, Helen.
Yeah, I've just put in there 20% of GPs are aged over 55. I would just like to say that Andy and I have been visiting practices every single week over the last few months, and there is variation. We do know that there are areas, more in the rural areas, that they are finding it easier to recruit, and we also know that we've got more challenges in the urban area, particularly Gloucester City, and that is a focused piece of work that we're actually working on now.
So, David, do you want to come back?
Just to say, if you could just send the numbers, I mean, it would be useful to get a handle on the age profile and also, as I say, the breakdown of the nature of GPing there. That's fine.
But can I piggyback onto that, because Andy Seymour and Helen and others will know, David, that I've been asking for information around the distribution of GPs around the county. I just want to see where they are all based. For hopefully obvious reasons. And Andy has assured me that work is being done. And I think that will add to the information that you've asked for, you've requested, enable us to see a broader picture. Does that make sense? Okay, so Councillor Andrews, you were next.
Thank you very much, Chair. I've got a couple of points, but I think they're related, so I'll try and give them both at the same time. Under the ways of working previously, before PCNs and so on, doctors' surgeries were contracted to have patient participation groups, and there was a very successful relationship built up in certainly some of the surgeries, which I think has helped with the next issue, which is to do with access and trying to get in terms the message out about either the surgery is open, don't go down other pathways if it's inappropriate, or indeed think about which pathway you use, and all of those sorts of arguments. But what we haven't seen yet is anything for patient participation at the, certainly more generally, at the PCN level. And I just wonder when that's going to happen and how we're going to make sure that the some of the good things that came out of PPGs and surgeries is transferred to the PCN level, particularly when it comes to patient participation in deciding what services might be prioritised as part of the contract.
I'm happy to take it, Andy. I'm absolutely spot on, and I think you are correct. We do need to bring patient participation voices into the PCNs. I have to be honest, I thought and I had hoped we would be further ahead on this. I have to say that the last 2 years have put us back slightly in terms of the development of the primary care networks, and Becky has done an incredible job in terms of bringing the PPGs together. And the next phase really is how we make sure that we get that voice on the PCN. So I agree. and it's something we need to be prioritising.
So have we got a timetable for and a sort of an approach to achieving that?
So I think the best thing from my perspective is to develop something from April with Becky. I would like to personally, what always works well is test it in the places that already have fantastic foundations, because where you really demonstrate it works, it then actually, we get the lessons learned and shared across the whole of the patch. So if we could work from April, I think the next few months are going to be extremely challenging from a primary care network perspective. But I think that PPGs are part of the solution, not the problem, to be honest.
And then to pick up on the second bit about access and the routes that people take. I'm a community first responder with the ambulance service, and certainly I still come across people who end up getting directed, having had a call out, to go and see their doctors the following day. So when I say directed down that pathway. And there's still that sort of issue of people sometimes reluctant to get in touch with surgeries. And I just wonder whether there's any campaign due, particularly as we move towards perhaps an even worse part of the viral season in February, to remind people of different access routes.
Yeah, thank you, Councillor. I think it's a good points made there, and to be honest, there are lots of ways of answering that. But first of all, and I would point out that I think you kind of referenced, our surgery is open. Surgeries have been open throughout the pandemic, right across the county, except for possibly in the very, very early days, one or two surgeries might have been overcautious and had closed doors to start with. But after the first week or so, every practice across the county has been and remains open. So I think that is something that I know something is said out in the public, but practices have always been open. And in terms of access, again, we have to be mindful of the fact that activity is really grown, and backlog, of course, is contributed to that. And just as an illustration of the size of the issues, some of our bigger practices in Gloucester City, where there are 30,000 population, they are taking 1,500 to 2,000 calls every single day. So it's a huge amount of demand on practices. That on a back of the envelope figure, that translates to about 30 to 35,000 calls into general practice throughout on a daily basis. And clearly we need to offer other ways of accessing advice, accessing services. And that's why we've really pushed the use of the practice websites and directing patients to alternative means of help, for self-help, for instance, for pharmacy involvement. And that's why we pushed the digital platform that Helen mentioned, which is e-consult. So many practices will be able to manage inquiries through effectively like an email and a response like that. And I think also, just to finish with, I would come back to your first point, that's the use of the PPGs to kind of work with their local practices to highlight the particular ways of working. And I certainly know in my own practice that the PPG has been effective in that way. But nonetheless, there's always more to be done. And, I think it's the constant message we need to kind of get out there. And that's where we would value your support with your communities as well.
Okay, I think we all take that message back. Thanks, Andy Seymour. I think we all take that message back to our practices. So next, the Chairman of the County Council, Alan Proust.
Thank you, Chairman, and good morning. Thank you, Ellen and Dr. Seymour, for that report. I think that was as a result of concerns I raised in the Lydney division at the meeting before last. I am still picking up concerns. I mean, I picked up that your report is pretty well generic. Have you got any mechanisms to drill down to ensure that I think, Andy, you touched on this just in your last few words, to keep and monitor the practices that we are picking up as community leaders that are slightly below the norm?
To pick that up, absolutely, and there's a number of ways that we do this. First of all, the data can sometimes be flawed, so what we try and do is choose different methods. When I said that Andy and I are visiting every practice, that's about 4 or 5 a week that we're actually getting through. That's local intelligence. What we want to understand is Often where there's access issues, there is often workforce issues, there are often resilience and sustainability issues. So we have to take it in the round. So we can drill down by practice and primary care network, but what we also need to know is what is the soft intelligence. We do know that there are challenges around access in certain parts of the county and in certain practices. So in answer to your question, we can look at the data. We cannot always trust the data because it's all about coding. So very often somebody can look poor in one element of access, and it's because they haven't coded it properly. But when we visit them, we can then get a greater understanding what the challenges are, and then we put in support.
You, Ellen, I'm reassured on that one. You mentioned earlier about the Colford and Lydney. I would be interested in the next few months to share, if you could share the strategy with you for the future of primary care, certainly in the South Forest area, and if we could get a little bit more meat on the bones on that. On a more positive note, I would like to commend you for the vaccination centre in the South Forest, Bream, just outside Lydney, which is acting absolutely superbly at the moment, and I think you've done a damn good job there. But thank you very much.
Thank you.
So question from me just quickly before I take Stefan. Andy and Helen, do you have a way of taking back to your colleagues comments like the very positive one we've just heard from the chairman of the county council to say today at HOSC, not bigging up HOSC, but the fact that elected members are taking the time and trouble to say, hey guys, this is exceptional work in my patch, thank you. If you could do that, that would be so helpful, thanks.
Yeah, certainly. We're definitely happy to do that. I'm keen to do it. But Helen and I regularly meet with the clinical directors of the primary care networks on a monthly basis, but we're often on daily contact with them through various WhatsApp groups, and they can then cascade down to their practice all the information. So I think we're meeting them on Thursday. We will feedback this from this meeting today. Absolutely.
That's excellent. Thanks a lot. So Stefan Firth, go for it, and then Stephen Hurst. Stefan.
Thank you, Chair. Morning, everyone. I just had to thank you for the report. My question is more about the morale. I think it was very interesting what you put in the first couple of slides about morale, both issues nationally and locally. I was wondering how you're capturing morale. What's the sort of data that you capture when it comes to those sorts of issues, and then what measures are being put in place to sort of up morale? Because obviously morale must be massively important to determining the performance of people and how people are feeling. And there's also an element of actual paternal care that we should have for staff who are going beyond the call of duty at the moment, particularly in the context of COVID. So I'd be really interested if you had any information on that. Thank you.
So if I start, and then Andy takes a clinical view on this. So one of the key measures obviously is sickness. We have access to understanding who's off sick and why from a high level perspective. We also have other methodologies in terms of, there's now a digital pilot that's taking place at practice level, which is all practice staff, and it checks in with them each day to see how they're actually feeling. We're looking at how much that would cost to commission across the whole of the county, because it's a fantastic opportunity for the practice staff, but us also to understand what is the mood out there. And actually, to be honest with you, it's sometimes more positive than we think in some instances. We also know that we meet with the practice managers on a monthly basis, and we understand the challenges and concerns that they raise. We are very fortunate, Andy and I, that the relationship that we have built up with general practice, that there is very little hesitation in picking up the phone and telling us when there are challenges, because they know that we have support packages that can go in and support, whether that's parachute pharmacists, parachute nurses. We've got a locum agency. So it is quite a few strands in terms of coming together and understanding, but sickness is one of the biggest things that concerns me the most. And the other thing is that we have been putting in place health and wellbeing support into GP practice, whether that's mindfulness, and that's been working with the local medical committee and other colleagues, and that's gone down very well as well. Andy, do you have anything to add?
Yes, thank you. I mean, I was going to mention that the LMC, the Local Medical Committee, which is the group that represents all the practices and works closely with them, and they run a service for doctors, particularly who are struggling with often with mental health or stress-related issues, and that's confidential, so we don't know the detail of it. But they tell us that there are more people involved, so that's how we have the information. And in terms of the morale, well. It's not been helped by national media campaigns, which have probably been misinformed, to say the least. But we, as Helen said, we have very good relationships with the practices. The primary care team is a fantastic CCG team and works very closely with the practices. And we do get told by the practices that, yes, morale is poor, it's nationally driven, but they do feel very supported by the CCG. So I think we're doing the best we can under difficult circumstances.
Great, thank you very much for your answers.
Sorry, I'm just trying to unmute myself. In your presentation, Helen, you highlighted the fact that staff, and you mentioned receptionists, are often in tears. I'm getting on now, and I don't get as angry as I used to, but I get so angry when I'm sat in my doctor's surgery and I hear people bad-mouthing the receptionist because they were too late in getting their prescription requests in and all that kind of thing. And for that, they blame the receptionists, the GPs, the health service, Boris Johnson, everybody. And I so want to tell them what I think of them for doing that. But sometimes people don't look further than the end of their nose, leave things to the last minute, and then take it out on the last people they should be taking it out on. And I get so angry too when I read the number of assaults, for example, on the employees of SWAST. Sometimes you wonder if we're all in the same planet and all part of the same country. It really is totally unacceptable. And I think all of us, as you were just saying, need to thank our GP surgeries, our own practices, and assure them that they do have the support of the vast majority of the people that we represent, because they certainly do have that. But it just makes me so frustrated when people take things out on the wrong people and don't look inwards and say, perhaps this is my fault that I didn't get this in on time. So to go off on a bit on that, I feel quite strongly on that.
Thank you.
So, Stefan, who is it next? Dilys Barrow, you've been very patient, and then Stephen Hurst.
Thanks very much. I'd like to begin by saying thank you so much for your presentation. I know that GPs are under incredible pressure. I'm so sorry to hear about them feeling unsupported and burnout and all that sort of thing. Now, I noticed in your report, you said something about that there's a local trend that GP levels are deteriorating. And I'm just wondering whether, there are any particular reasons for that. I'm wondering if we as counsellors or as councils are able to help you in any way in support and in making GPs feel a little bit better perhaps about all the work that they're doing because it's so important. And just something that interests me on the positive side, I read about the simple COVID oximetry at home thing that you've got underway, and I happen to know a resident who was helped by this and was taken into hospital at exactly the right moment. And it was really very, very helpful. I just wondered if you wanted to say anything about that. Thank you.
Andy?
Perhaps I'll say something on the on the second part, and Helen, you pick up the first issue. Excuse me. Yes, there's this thing called pulse oximetry at home, or we've often referred to it as a COVID virtual ward, and it's been a very successful project. We were one of the first in the country to set it up, and as you said, it's basically a system whereby patients who are probably at slightly higher risk of being admitted to hospital are put into what's called a virtual ward, where they're monitored remotely. They have a pulse oximeter where their oxygen levels are monitored on a daily basis, and so that if there is deterioration, that can be picked up early, and if a patient does require hospitalisation, that can be done at a very early stage, and therefore outcomes are so much better. And we've had lots of people go through those wards over the last year or so. Obviously, with Omicron cases being high, there've been a lot of patients on the number in the ward at the moment. end of last week, we had 270 on the COVID virtual ward, the oximetry at home service, but very, very few of these are now being admitted to hospital, which is a good sign in terms of the way that Omicron's playing out. But having said that, we have prevented many more people going to hospital at a time where beds are at a premium. So I think it's been a really good service. There is another element of the service which is the key is working in partnership with secondary care. Secondary care colleagues are able to stand down patients who have been in hospital, are stable, but perhaps still need a bit of monitoring, and they can be monitored at home again by oximetry, and that's a COVID virtual ward. And we've got around about 17 or 18 patients in that system as well. So again, it's about optimising bed occupancy, providing a best service for patients, but yet keeping the system safe as well.
Thank you for the question, Councillor Barrell. I really just want to emphasise this is absolutely key, and I'm glad you've raised it. One of the things, there's a number of things that we're doing. The numbers have gone down. That's the first time, really, the trend is going in the wrong direction for Gloucestershire. So we've got to put every effort into this. And so part of our armoury is to build our training practices. I've talked about the beautiful premises that we're building. That allows us and enable us to get more training practices into Gloucestershire. The evidence shows that if you are a training practice, you have less challenges around recruitment of GPs, because often if they train there, they love it. And it doesn't matter what part of the county. So the biggest challenge for us was Gloucester City, inner city, and Forester Dean did not have enough training practices. So we are building on that, and not just for GPs, for nurse training as well. The other thing that we're doing is that I said to you before, the positive side of this is that we are seeing GPs coming into the county to work in Gloucestershire. We've got a good reputation, and certainly they are choosing areas that they want to work. But what we're working on now is finding out how can we attract more GPs into the inner city areas where it is more challenging. It's a different type of general practice to some other parts of the county. We've gone out to advert and we have been successful in recruiting health inequality GPs. So those are GPs that we fund for them to do a project in the community, whether that might be around asylum seekers or drugs, mental health, sexual health, all sorts of things that they have got a specialist interest in, so that we invest in them, they invest in our community, but then they work as a GP in those areas. The other thing that we did a few years ago, and I thank Becky and Anthony Dallimore, we did a big campaign, come to Gloucestershire to be a GP. We did videos, it was very impressive, and we did get more GPs coming in. So there is a whole armoury that we are working on at the moment, because we are not going to have our numbers going down, we're going to build on them. And we believe that GPs really will enjoy working in Gloucestershire.
So, Dilys, do you want to come back?
No, I'm really pleased to hear that and to hear about all the work that's going into it. As you say, it's really important. And, you know, do pass on our good wishes to GPs generally.
No, I think that's a fair point, and I think at the end, when I try to sum up, I'll request that you do just that. But picking up also points, you know, about individual practices that, for example, the chairman was making. Just to Helen and to Andy, if there's anything at all that the county council can do to help you convince would-be GPs to come to Gloucestershire, do let us know, because I'm sure we can find you additional promotional material to let you know. Maybe an email from the chairman of the county council saying, "Great area, come and work here, guys." But seriously, I'll make a serious point, although maybe a little flippantly. So I think next was Stephen Hurst, and then Helen Molyneux. Did you have your hand up? So Stephen.
I think Jill Mosley has a hand up after Stephen.
Okay, perhaps that's right. Thank you. So Stephen, do you want to contribute now? You're on mute, Stephen. Stephen, you're on mute. Or am I on mute? No, you're on mute.
Can you hear me now?
We can hear you now. Yep, thank you.
Good morning, everyone. As I drive away from Shire Hall, I pass a huge building, a new building, which has been built on the site of an old car park, which is festooned with lots of NHS banners. And I presume that that's a new district surgery complex. Would you mind just explaining to me what that building is for and how it fits into city centre primary care? Thank you.
Thank you, Steve. I presume you're referring to Quayside development.
Yes.
Yeah.
Yes, that's correct.
Yeah. No, it's a really good new development. We're really pleased that primary care have got some presence there. So they've got 2 surgeries there that have moved from other premises. So we got practice were based in the Park, Rickenall, and then they're called Sevenside GP practice, and also Gloucester Health Access Centre, GHAC, have moved from Eastgate premises to those premises as well. And as Helen alluded to, and as any GP would testify, moving to new premises energises them, re-energises them, makes it a much better experience for them and for their patients. And in fact, one of those practices was able to recruit to their GP team. And I think having very recently, I'm sure having good new premises was a key factor there as well.
So it's a great addition then to the primary care profile in the city centre.
Absolutely.
Great initiative, yeah, very great initiative for Gloucester City and for the NHS, Stephen. Are you okay with that answer? Thank you. So Jill, I think you're next, Jill Mosley.
Yes, thank you, Chair. Great presentation, very easy to understand. My question's about vaccinations. I've been made aware recently, locally, of the great difficulty of 2 severely autistic people, adults, who have problems with invasion of personal space and therefore extremely difficult to accept vaccinations. And I guess there may be other people with different conditions who also experience this problem. One of the people who alerted me has pointed out that she has written to her MP to ask what progress is being made in delivering different vaccines in a different way. So my question really is just about how do we deal with difficult people in this sort of spectrum and other similar conditions that make personal space invasion a problem? And also, do we know anything about a differently administered vaccine for these sort of people? Thank you.
If I start, and just to say that I personally would like to know about any instance where there is a challenge for the vaccination. So if I can take that outside of the meeting, but just to give you some reflection, the reason why we didn't want large mass vaccination sites with huge queues outside was actually to try and make it as local and as personable as we could, and selecting premises like community hospitals, GP practices, and even the fire station has done an incredible job welcoming certain populations. What we've tried to do is have sites that set aside days where they focus on certain groups that may need some more support. So that could be the learning disabilities, that could be children, that could be vulnerable shielded groups. And what they've tried to do is accommodate the way that they deliver the vaccination. I have to say, because there's a GP there at all times, as well as highly qualified nurses, it has given the opportunity for them to adapt and reflect on the needs. However, we are aware, even though our percentages of uptake are phenomenal, there will be some thousands of patients out there that have not accessed their first, second or booster vaccine. So I would personally like to know any instances where you feel that there are barriers so that we can actually make sure that we're accommodating for those. But I think that they have done a very good job trying to adapt low lighting, making sure that there's been sufficient space, no queues, longer appointment times. So yeah, they've made some adaptations, but I would really like to know where else we can improve.
Okay, did I see Paul Roberts on the call putting his hand out?
Just briefly, Chair, if I may, because we obviously...
Can I just interrupt you? I hope you're going to give them that fantastic example that you gave the presentation to HOSC.
I was going to mention that, Chair.
And so moving and so innovative, absolutely top draw stuff. Well done. Thank you.
So Councillor Mosley, I mean, obviously, as with Helen, I'd like to know the individual examples if I could be contacted privately, because we have teams that support vaccinating people, whether there are some real difficult challenges with the individuals concerned. And those members of this committee that were able to come to our informal meeting with the HOS committee will know we presented a number of examples of that, including the intensive healthcare outreach team, which works very closely with people with neurodiversity and learning disability. And the example the chair was giving was where we had a service user that we worked with who was very scared about getting their vaccination done, but the most comfortable place that he had that where he was most comfortable was in his hot tub in the garden. So sure enough, one of the intensive health outreach team got their Speedos on, got into the hot tub, spent time in there with him, getting to know him and work comfortably with him, and got the vaccination done in the hot tub. We also had a story about a guy who had a favourite football team, so the vaccinator put on the appropriate football shirt and again got very comfortable. So they're very, very good. They're very, very skilled. They're very, very good at getting those vaccinations done where there are particular challenges. And if there are examples where we've not done that, I mean, it sounds as if you might have a couple. It would be really good to hear about them because we can get in there and get it sorted. I'm absolutely certain about that. So please let me know.
One of the frustrations, Paul and Jill, is that these stories, these fantastic, innovative ways of working, don't seem to hit the headlines, and we always get the grumbles and the fact that somebody had to wait an extra 5 minutes. And I remember particularly the football kit story because I thought it was so clever, and the lengths that your team went to ensure that this person got their jab and follow-up booster, hopefully, was just I call it top drawer, top dollar, top drawer, whatever.
They're absolutely committed. They're passionate about doing it.
Oh, absolutely, and please again take our thanks back to your teams. Jill, does that reassure you? Because those examples were really good.
That's brilliant. But I did ask also were there going to be other ways of administering the vaccine orally or anything like that? Do we know?
I'll leave that to Andy. Do you know, Andy? You're on mute.
Not yet. No.
Okay, so Jill, thank you for your question. I'm just starting to get slightly conscious of time. So we got Ray Padilla from Gloucester. Ray, you got your hand up. Ray, you're on mute. Or am I on mute?
Yes. Thank you very much, and good morning to everyone, especially to Helen and Andy. Thank you for the report as well, because at least this has given us a solid basis going forward. I just would like to highlight your highlighting of convincing some of our would-be GPs to work in more challenging areas in the county. Right in front of me, I'm looking at the health deprivation and disability domain in the 2019. Let me just check. This is about in the 2019 indices of deprivation for Gloucestershire, and interestingly, 12 of these areas are in the city of Gloucester, with the 2 others in Cheltenham, St. Paul's and St. Mark's. I'm just wondering whether we would be doing a more aggressive recruitment, attraction campaign to convince GPs to be in these areas, because apparently they're more challenging. And also, if we can consider these 14 areas in the health and inequality GP scheme, because I think this would really help address prevalent issues in these areas.
Yeah, thank you. Really good question, really good point. And you will know that COVID has highlighted and exacerbated the issues about health inequalities. And I think this is something we're absolutely going to address, both from primary care perspective, but as an ICB going forward, because this is absolutely key for us. And Gloucester City, parts of Cheltenham, parts of Forest are areas we're going to really focus on. And health prevention, health behaviours comes down to primary care. So we absolutely recognise that. Helen's already touched on the initiatives we've kicked off with health inequality GPs, but we've got plans to take those even further. And we probably need to look at more innovative ways of delivering primary care than the traditional ones. And there's a traditional list size basis. We need to look at different ways of doing that. As it happens, Helen and I have got a meeting next week, I think, with some of the key lead GPs in Gloucester City, just to work through some options, work through some models. And with that, we'll come with looking at those areas you talked about. There's something called Core 20+5, which is an initiative to look at health inequalities, but particularly looking at certain clinical areas where we know that people with health inequalities will come to more harm, such as early cancer diagnosis, high blood pressure, and so on. So that it's all linked into the work we're looking at. So very good question, and I can assure you that we're onto it.
Yes, just two of the places that I'd like to mention, Matson and Robinswood, which I represent in the City Council, and also Podsmead. In Matson, for example, I had a chance to speak to the practice manager, and she told me that Matson is only open, the Matson Lane surgery is only open for like 3 full days and 2 half days during the week. And it has got like 6,000 patients to cater to. So we really would like to see the local surgery, open like, in fact, 7 days a week if we can manage, just to address the health deprivation problem in the area. Sorry.
I'm just going to add on. The other thing that we're learning is, I know general practice is always seen as the GPs and their practice staff, but in areas that you've just described, Matson, Podsmead, Inner City, Cheltenham, and also Cinderford as well, the relationship and the close working between community and primary care is absolutely key. I mean, Paul has described the work that he's been doing and leading around the equity vaccine. But what we recognise now is we need to take that to the next stage and look at health checks, early diagnosis of certain conditions, and use the same methodology that we used around the vaccine equity and getting into populations, because our services aren't always easy to access. Even if you had them open 7 days a week, it doesn't necessarily mean that the patients or the locals would actually access health services in that way. So as well as building our primary care provision, the work that we've learned through the vaccine equity group is absolutely key, and getting out to our populations and doing those health checks and getting early diagnosis so that we actually improve health outcomes is key.
But just following on from that, Ray, that's why I come back to the point that I made at the beginning. Sorry, just reading a message to say YouTube has crashed. That's one of the reasons I'm very keen, as Dr. Seymour and Helen both know, and Becky, to get the GP distribution around Gloucestershire looked at, so we can see, we as a committee can see where the GPs are actually based, and maybe from that, Ray, follow up on the issues that you've just been describing. There's no implied criticism at all in wanting that information, but I think it will help us, particularly after there were quite a few editorials on GP distribution around different counties in the Times a few weeks ago. I'm obviously not a GP, but they were pretty informative, and the Times ran a good series on them, and that's where my interest sparked from. Okay, so have we got anybody else left indicating? I can't see. Oh, sorry, I do apologise. Please go for it. Thank you. Yep.
Hi, thank you. Helen, thanks for a great presentation. And if I could just add to a response to a question asked earlier about feedback. Of course, Healthwatch do provide feedback around the patient experience of GP services. It is the issue we hear the most about. And the nature of the service we provide, it tends to be more negative than positive. We try to provide as much positive as we hear. There will be information from the quarter we're just about to end that will be provided, the information that's come to us. We also ran a survey last year looking at patient experience of primary care, and provided that information to look at what sort of actions, met personally with Andy and Helen to look at what we might do with that. And we'll be revisiting that in a month or so to see, have we still got some hotspots, and is there more that we can do? So that aside, my question, really back to Helen, in your presentation you talked about relationships that needed to be rekindled and reinvented, and it's not across, it's not every practice where that's been the case, but certainly in some areas. I just wondered if there are any specific plans to take that forward.
So thank you. And I think this is the thing that I wanted to end on, actually. So I wanted to just take this opportunity, is the importance of the positive relationship between the patients and the GP practices. And it's been one of the things that has been so upsetting over the last 2 years, because we feel that we've actually taken a step back and we need to get it back. So we've done work with Anthony Dallimore and Becky and others to try and re-emphasize to the patient population that the GP practices are open, they're trying their best. Can we, be patient and be kind? And that can't be one-way traffic, because we obviously say to the GP practices, remember, your patients have had a horrific 2 years as well. So there is this media campaign that we're trying to re-emphasize the importance of the relationship. With your help and with your input, it's really helpful to see where our pockets are, because it is not all over the 71 practices. And what we've then got to do is work with Becky and the PPG and the practice to say, how can we rebase this? How can we make sure some practices are brilliant at having open days and, really, making an effort to get to know their patients, not just from a health perspective, but many haven't got the opportunity. So we have not got that completely licked yet. We do need some help. I don't know whether you have anything to add, Becky, in terms of our next steps, but it is about working with Healthwatch and the PPGs and the practices.
Yeah, we've got one of our regular PPG countywide networks coming up in a couple of weeks' time. And it is one of the questions that we're going to be talking to PPG members about there, is that obviously COVID isn't over. We don't know when it's going to be over, but what can we do to start to sort of reignite some of those relationships, which for obvious reasons have had to slightly go on simmer over the last few months. So yes, it's something we'll be addressing. The meeting, I think, is the last Friday in January, so it's only a couple of weeks away.
Okay, is that helpful? Okay, I don't see any other hands up, and I am conscious of time. I just wonder if we can begin to sum up. So Andy and Helen, thank you so much for the time and trouble you've taken to not just answer our questions, but to put together the report in the first place. Something very, very welcome. And you'll have seen from the interest of our host members that they've read the report and have come up with some really cracking questions. I think probably best if you and I talk offline and agree some form of words that you can send to all the GP practices, I think, in Gloucestershire, not just the ones that have been singled out today, but we can pick up the individual remarks. And also, I'm very keen for us to get as much information out as we can as elected members to our colleagues about the ways in which we can work with you and help our constituents, the people who we represent, work with you too. It's a bit of a PR job to be done here. And I think as elected members, we probably have a role right across our communities. Looking across at my screen, I see some heads of nodding heads of approval there. So we are all in it together. Believe you me, we are all in it together. We all have our part to play, whether we're elected members, GPs, to the various trusts representative bodies who are here today. So it's just a huge thank you, and we will talk, Andy and Helen, offline to try and agree a form of words where we can get a two-way exchange of information going. And final word to Helen, if you need the cooperation of the County Council, please take it up to ensure that we give you all the promotional material we can give you to persuade any GP who's wavering about coming to work in Gloucestershire, that final shove that they need to say, okay, I'm sold, I'm going to apply for that job and get it.
Thank you.
Okay, so thank you so much. Sorry, I waffled a bit there, but it's obviously something that's close to all of our hearts. Okay, on that note, I thank you and move swiftly on to the next item on the agenda. But thank you so much, guys. So, taking a deep breath, that takes us on to looking at my idiot's agenda. Item 6, and that's down to Ellen and Dame Jill. Dame Jill, particularly welcome to you. It's your first meeting, I think.
It is. Thank you. Can you hear me?
Yes, certainly, loud and clear.
Good. Because I apologise at the beginning of the meeting. I was fiddling because I couldn't get any sound, but I'm linked in now. I thought what I would do is very briefly talk about what I think the ICS is, then hand over to Ellen to talk about the presentation. when you read the documents, and there are so many documents coming out of the centre, it's very easy, I think, to lose the will to live, because they're trying to give guidance on a whole set of things. And it's particularly challenging for ICSs because we are the first construct in the NHS, which is incredibly different. So if you look at Gloucestershire, we are very privileged. We've been working closely together. We have one-to-one relationships between our acute trust, our community and mental health trust, our CCG, our county council, and therefore we have a set of relationships which have developed over time. If you're looking and you're an ICS in other parts of the country, if you take South Yorkshire, for example, there are 7 different local authorities, 8 different acute trusts, about 14 other trusts, all trying to come together to create a new way of thinking about doing things. So we stay sane in Gloucestershire by thinking about all the opportunities we have, because actually we've been at this for some time, because partnership is the way we want to do things, and we're simple in terms of our constructions, and therefore we can go further in what we're thinking about. So I think in Gloucestershire, we're really about 3 things. That's what the ICS is trying to do. The first and the more traditional thing, which the NHS has to do, is make sure that we deliver services today as well as effectively as we can, and that we recover from things like COVID. And you've already had, I think, well, for me, an inspirational presentation about some of the things that are going on in primary care. But I know at other times you've had similar presentations about the really fantastic things that go on within the hospital and the community organisation. And everybody works together in Gloucestershire as well as I've seen it anywhere in the country. And I think people should be proud of that. And that includes the sort of relationship with HOSC and with the county council. In the new world, there will be what they're calling an integrated care board. But what's really important about that is it's a very new type of organisation, because although it'll have the traditional NHS organisations, the county council, both through a nominated individual, but also through the Director of Public Health and the social care involvement, they will be members of that group. They're not being separate. It isn't something the NHS is doing in one place and the county council elsewhere. We're in this together, and we'll be in this in all those meetings. And that job of that board is to use the money as wisely as we can to get into the sorts of really important questions you are asking about the distribution of resources. Do we use our money as wisely as we possibly can? Are we really focusing on the healthcare for the people who need it most, as well as all the other things? At the other end of the agenda, so that's the here and now. How do we recover? How are we the best we possibly can be? At the other end, and I welcome this because in a previous incarnation, I was a director of public health. We're about the long-term determinants of health. Now, that is clearly a county council responsibility, and we in the health service have to support and follow the county council in the work that's done with the Health and Wellbeing Board, and in the future that will be done with what they're calling the Partnership Forum. But it's very clear, you have the responsibility. Our duty in the NHS is to cooperate, collaborate, and make sure that the bits of that can only be done by the NHS are delivered. And that's about long-term determinants of health, but it's about supporting employment, it's supporting education. All of those things we know will make a real difference for the people who live in Gloucestershire for the future. But they may take months, years, 20 years to actually see the benefit. So the bit that is really different, and again in Gloucestershire we have the privilege to build on, is how do we get from what I think is a legitimate criticism of the health service, focusing on today, into something where we're making transitions and changes that will help us in the future. what do we do in this middle blocks? And you've already spoken about a number of the things that we're doing today through the presentations. We've got the transformation work, which is led through Deborah Lee and the Acute Trust. We've got the work that we do through localities, and that's primary care networks, but it's also the network of community organisations, voluntary organisations, district councils that sit around our localities. And it's also about what can we do with things like digital, and you've heard some really good examples of how digital is improving the linkages that we can make for the future. And in all of this, the biggest challenge for us in Gloucestershire is about people. We are, because we're a wonderful place, we have an ageing population, but we have a constrained workforce, which is a national issue. So we have to be really good in Gloucestershire about being a great place to work. And, you know, your offers of making sure that we make that offer jointly between health and with local government and with all the other bits that are out there. We have to be a place that attracts people in, but we also have to be a place that does things differently. Because if we keep doing everything in the future the way we do today, we're not actually going to be able to do it, because older population, fewer people in the workplace, and we have to think differently. So I think we're about these three boxes, and it'll come over as we talk. So I'll hand over to you now, Ellen.
Thanks, Jill. Hopefully see and hear okay. So on to the slide. There we are. Of the background, which I won't read through all of the words on the slide, but it's just really explaining for you as members the formal rationale and legislative reasons for why we're moving now into the formal integrated care system. So this is not new, and we have been working in this way since 2018, and the partnership is really quite well established in Gloucestershire. And so this is really about formalising something about the way we already work. Okay, next slide, please. Again, this is picking up on some of the things that Jill's already described to you much more eloquently. This is a very short version, but about distributed leadership, working collaboratively around the Gloucestershire Pound. It's about us working together all in an integrated way in our system and developing that longer term strategic view. So next slide, please. And this is in the legislation, this is what's described as the 4 fundamental purposes of the ICS. So again, I won't read this out. I think the instruction from Andrew was to keep my presentation snappy, so I am doing that. But these are the 4 fundamental purposes or pillars of integrated care systems as described by NHS England. Next slide. And this is just a graphic explaining those 3 main domains of work that Jill described up front. So we're about the now, about integrating our care and services to deliver the best outcomes for our population. We're about working for the future, so delivering better outcomes and understanding what those are through the wider partnership. But really importantly, that's listed transformation for the future and how we get from the now to the services that we want to deliver in the future, and indeed influence the wider population and health outcomes in partnership with you all and others in our system to work together to do that. Okay, next slide. So in terms of that, moving from the current way we work through a partnership to a statutory arrangement, we have got a set of design principles that we use. Again, Jill referenced it, but we have quite a bit of national guidance that we need to work to. We also work with the Southwest Regional team at NHS England, and they review and provide feedback to us. And we also have a series of opportunities to engage, such as today, This is part of that engagement, and also to co-produce with our partners some aspects of our system design. And we, as we've said, we think we are a successful system already, and we're not shy to say that, but I think also there are still huge opportunities to further improve and build on our successes. And again, just important to say, it's not a starting point designing the integrated care system. And indeed, this slide is already out of date because it says April 2022. And just before Christmas, so after these slides, I'd already completed these and gone on my break. The date was formally moved to the start of July. So that's our starting point for the statutory ICS now. And we will continue to dynamically review and build on our ways of working to improve and learn as we go and be a learning organisation. Next slide, please. So just this one for information. You don't necessarily need me to go through all of the detail, but if people are interested, these are some of the things that we need to produce around safely closing down the CCG. We have something called the due diligence checklist. We then produce a readiness to operate statement and a system development plan. Obviously, all very scintillating documents, and we are happy to share these as we start to develop and make these more available and accessible where appropriate to do so. Okay, next slide. And again, I've just included this. I'm not going to pore over it with you, but this is just to explain the current decision-making structure that we have within our system, bringing together programmes, our localities, our organisations, and then our wider groups, such as working with Leadership Gloucestershire and the Health and Wellbeing Board. And as we look forward and think about how we're going to develop that into the future, if you go on to the next slide, we have got an integrated care board and an integrated care partnership, and we're in the process of designing these now. And you can see that the functions are slightly different. So the integrated care board is about developing a plan, securing the provision of services within the financial delegated to our delegated limits for our system, and developing a capital and people plan. Formal governance around the resources that we're accountable for on behalf of the population. And then the integrated care partnership is about that wider vision for addressing health and wellbeing in our community, working very closely with local authorities and ensuring that we have the citizen and population voice into the development of our strategy. Okay, next slide, please. So this is my final slide, and this is just to really say about the importance of working with people and communities. And we do want to ensure that people can influence both the development of the ICS, which I realise might be a slightly dry topic for some, but much more importantly, the future vision and design of our plans and strategy and service development ideas. So we're going to ask people how would they like to be involved, what areas or issues they think are important as we develop our new strategy for the ICS, and the top 3 things we think could be done to improve health and wellbeing in our county. So these questions are going to be part of an ongoing conversation. We've got a platform called Get Involved in Gloucestershire, an online participation space, and we've just provided a bit of detail there about how people can access that. So that's all that I wanted to just discuss with the committee today, to just provide some information for you on the development of our statutory integrated care system. And myself and Jill are really happy to take any questions on any of that.
So Gillian Ellen, thank you so much for that. That's very clear. And I'm sure lots of questions. I can't see any hands going up just yet. David Brown's raised a hand, so my my prompt says here. David Brown.
Yes, thank you, Chair. Very interesting presentation. Thank you for that, Ellen. I'm a lay member of the, let me see now, Information Security and Access Control Group. And part of this group's responsibility is to develop or look at the DUI system, which is joining up your information, whereby the information that each separate area of the National Health Service and the Care Service provide are connected, so that it's more efficient support for patients. I wonder if you're able to say anything about this DEWI system, joining up your information, because we do rely on the public getting involved in that and, giving permission for their information to be shared. This might even be an area of interest for HOS to look at in more detail in the future. And I suggested as a suggestion for a future item for HOS to look at. But if Ellen, you could say something about the DEWI system, please.
Yes, I can, but I'm going to take it a little bit broader, if I may. Not being one of the digital experts in our system, but what I can say is fundamental to the joining up of services is you're absolutely right to pick out the DEWI point, is about the joining up of information. Absolutely. That there is a digital strategy that runs alongside the development of our integrated care system. And one of the first things alongside our integrated care strategy will be the development of an integrated digital strategy. We expect to be able to pull that into something that will be more of a public facing document. I would like to say March, but for safety, I'm going to say the summer. And I think it would be a really interesting thing for us to come and share with you in the HOS to talk a bit more about DEWI, which is one part of that strategy. But there is a whole range of things, including some of the things that Helen talked about earlier in her primary care presentation, about how we enable consistent delivery of care pathways through digital support to our clients and decision support, about how we provide online access, about how we join up information, about how we address issues such as some of the more harder to reach groups, and how we address issues of digital inequality as well. And all of those form part of the digital strategy that is being developed at our integrated care system level, alongside the national digital strategy, which is part of the work of NHSX and NHS England. I don't know, Jill, if there's anything you would want to add to that. I think this is something we could bring in the summer.
Yeah, I think you're making a really important point. There's two bits. There's about information, where we need to have better shared information so we can help people follow their own journey and help us target resources. And some of the questions have been about information. And then there's a technology strategy. They're not necessarily one of the same, because you can make progress on either or both, and we want to do both. So some of the conversations we've been having is, how do we make sure that all our data sharing is as good and effective as it can be, that it's absolutely crystal clear to people what their information is being used for, so we can actually target resources. And again, some of the questions earlier today were exactly in this sort of box. So it's vital we get information, but it's not one and the same as IT. It's both and.
So David, does that answer your question? Good answers there, very full answers.
Yeah, that's fabulous. Thanks very much. I mean, I do think that when the time is right, that HOS do take a closer look at.
I'm sure our colleagues will keep us updated.
Yeah.
Okay. So several hands going up. David Drew, then Stephen Andrews.
Yeah, thank you to both of you for the presentation. I mean, can I just understand? I mean, clearly at this time, the limited amount of disruption to staff and so on is really quite important. I mean, what is happening to staff? Is there any movement at all? Does anyone have to sort of change their salary basis or where they're working, or what their pension arrangements are? And also in terms of where people are located, I mean, where are we with this?
It's a good question.
The rules are that, and again, we're in a privileged position because we have one CCG which is migrating and moving into a successor organisation. So if you're sat elsewhere where you've maybe got 6 CCGs coming together, the answers would be very difficult, I think. But where we are is that from the 1st of July up until the 1st of July, everybody working for the CCG, with a tiny exception, and I'll mention that, is guaranteed that their role will continue in exactly the same way. They'll still be part of the NHS, they'll still get their pension, they'll still get everything. From the 1st of July, as we start doing things differently, it may very well be that things that are previously done by the CCG might in the future be done by a trust. The same task, but it might be better done in a different organisation. And for people then affected by that, 2P would apply. So they would move with the job.
So can I just interrupt you? How many people would that affect? How many people?
We don't know. We don't know. This is a conversation that we're having with the staff.
But I'm trying to help David with his question, specifically in terms of numbers. And I mean, I think we get the drift, David.
Yeah. So people have got a guarantee of employment. Where they're employed may change, but that takes a period of time. The one group without a guarantee of employment are the executive team. And the view was the ICS is so substantially different that that is not the same. And that's what we're working through at the moment. And there's a consultation with the people in the CCG about exactly that at the moment. And, you know, Andy, as the chair, I don't know if you want to say how that's going.
Yes, it's, as far as I understand, it's going well, because these are individual conversations with executive members. But it's the company, external company involved in talking to exec colleagues and reassuring and working with them to hopefully, I'd say reassure.
So I think we get the picture. David, does that help you?
Yeah, that's okay. I think we need to monitor this, though, Chair.
No, I think you're right, and we can get updates. Thank you. So, Jill and Andy, thank you so much. So, Stephen Andrews, then the Chairman of the County Council. Then,
thank you, Chair. My question is really around the whole issue of overview and scrutiny of the ICS, which you commented about there being loads of stuff to read. There is lots of stuff to read, except there does seems to be very little to read on how scrutiny is going to happen in the future. And I just wondered, as you develop your structures, how you see the overview and scrutiny element being developed alongside them. I'm not sure there's such a word, but to make sure that they are scrutinizable.
well, that's our job, to make sure they're scrutinizable, because if they're not scrutinizable, we just go back and say, hey, make them I think we've invented a new word, make them scrutinizable.
But if you like, at the moment, there's the health and well-being angle. So there's
I get that.
There's and so there's I'm just concerned that some clarity in how we work is being developed in parallel.
Sure, I get that. Thanks, Stephen.
I think it's actually quite important on this issue, because NHS England have basically forgotten that there is a thing called health and overview and scrutiny. They've forgotten about this. So they've tried to build scrutiny through the partnership forum and its specific responsibilities. But I chair the National ICS Forum, and I'm working with the LGA to say, don't forget overview and scrutiny, because that actually brings something really important into the dimension of what we do. But you need to be approaching the LGA, because it's been forgotten in the central guidance.
Okay, well, I'm happy to get in touch with the LGA at the conclusion of this meeting, but I can assure you we won't let you forget about HOSC, and all the members here are pretty
Absolutely.
Okay, well, I'm happy to take it up with the LGA. Thank you for the heads up on that. So, Stephen, do you want to come back?
No, I think we do have to, as a committee, though, take it up with the LGA.
I'm happy to do that.
And but if you like, we need some clarity, I think, from. I mean, we are in a better position, arguably, because we are one organisation covering one county and not trying to integrate several CCGs. but starting from that good position, we should be ahead in proposing how best the new structure is scrutinised.
No, that's a good point. Okay, so who else was trying to speak? Any other hands up? David Drew still has an old hand up, as David Brown has. Anybody else?
I can see Alan's hand. Alan.
Oh, sorry, the chairman of the county council. Sorry, Alan. Yeah.
Alan. Thank you, Chairman. A slightly tongue-in-cheek question. We've over the last few years had a fairly robust debate on the future of the forest hospitals. So a lot of staff will be retained on the ICS and the CCG. So quick question, how do you see the ICS, if at all, fundamentally improving on what the CCG has been doing now and previously? Are we, for instance, going to see better localised public consultation? Thank you, Chairman.
I have a personal view, and this has to be worked through the board, so you're hearing my view, that one of the jewels in Gloucestershire is its locality working, and that if we're going to be more responsive to people, then we need to think all the different tiers. There's some stuff we can do as a county. There's some stuff we can do around individual practices and individual organisations. But actually, the place where an awful lot of this comes together is around locality consultation, and district council boundaries give a useful framework. So I hope as we go on, you will see more stuff happening at that level. Because that's where the councils come together. That's where things like housing, which are really fundamental for people, that's where the voluntary sector often organise. And if the ICS can't, in Gloucestershire, capitalise on that as a basic building block of what we do, then I think we will just be doing more of the same. But that's a personal view. I have to sell that to the ICS.
Well, can I just add something? I was going to say, because I think we have had quite extensive, many discussions around the services in the south of the forest and the Forest of Dean hospitals. So I just wanted to just log that it doesn't unpick any of the decisions that we've already made and the process that we're on. So we carry that legacy forward, as fond or not as we all may be of different aspects of it, but we'll always, as I said, build on the things we've done well, and improve on the things where we could do better, and always happy to hear feedback where you think we could do better.
Yeah, we're pretty good at feedback, I think, as a committee.
I think so. I think
hopefully that won't change.
Chairman, can I just say thank you to Dame Jill and Ellen, but I just couldn't resist that one. Thank you very much.
No, sure, it was. And Dame Jill's answer was I'm trying to think of the right word, quite skillful in the way she answered it. I was listening very carefully. That's interesting. Cheers, Jill. Is it okay? By the way, is it okay to call you Jill, or do you prefer Dame Jill? We try to be a very informal.
I'm Jill. I'm Jill.
Are you sure that's okay?
Yeah, there's only two things about being a dame. You get lots of offers for pantomime, and you get an irresistible desire to wear tweed. So call me Jill.
Okay, so we are an effective host, but as you'll have seen, hopefully pretty informal too in the way we work with titles, all that kind of thing.
And I'm a great supporter of the HOSC system. I've been around in central policy when it was being developed, and I think it can be really important in going forward, because there has to be a different sort of scrutiny. The other relationships are about partnerships, how we build them together, but you have to have some grit in the oyster, and your grit.
Oh, I thought we were the oyster. Hang on. Anyway,
no, the grit is the important thing. Without the grit, you'll never have a pearl.
No, okay. I wish I hadn't said that, because we're moving on into an area that makes me hungry. Okay. So, any other questions to Ellen or to Jill? Is it's okay to call her, please? Stephen Hurst.
Thank you. Hope you can hear me this time.
Yeah, we can hear you.
I think that we're really very fortunate in Gloucestershire by having the the structures that we are already working with. We've got one county council and we've got 6 district councils, and things are starting to come together to make a whole. So we are really very, very fortunate.
Sure. And I'm just going to wrap this up now by saying, and hopefully Jill has noticed, that this HOSC is effective, it is informal, but very, very importantly, it operates in a very non-political way. I would invite you, and I'm not going to ask you to, but I could invite you to identify which members belong to which party. I'm not interested in the slightest in having political point scoring at HOSC, and long may we continue to work like that. That's a very key element that makes this HOSC effective, I think. Okay, so on that rather serious note, if we can move on. So I think looking at my idiot's guide that Joe always prepares for me, we're on to item 7. Temporary service change. But Dame Jill, thank you so much for sparing time to talk to us today, and we look forward very much to working with you very closely, and also continuing to work with Ellen. Thank you.
Thank you very much. It's been an honour, and as feedback to you, because often you like to think this is how you're seen. That's exactly the feedback I've had on HOSC from everyone I've talked to in the system about it's apolitical, it genuinely tries to ask questions that help us improve. And if we can keep that up, I think we have the real opportunity to push on and create beautiful pearls together. So thank you all very much for allowing me to join you.
So I'm sure we're going to keep this image of beautiful pearls, and also Councillor Andrews' new word of scrutinisable, to make sure that we are all scrutinisable.
Yeah,
okay.
Great.
Okay, that's really good. Thanks so much. I'm just conscious of time as well, so we do need to crack on. So item 7, Simon Lansley and Ellen again. Is that okay, please?
Hi, yes, thank you. So I've formed a new double act for this item. So it's myself
cool.
and introduction, and then if we need more detail in the Q&A, then Simon will aid me.
As you know, we've all had the papers. Just very briefly, if that's okay.
Yeah, I will keep it really brief, and I don't think we've got anything. We're not going to share any slides or anything on the screen.
Okay, good. Thank you.
It's really about informing you of an emergency service change. As you say, the paper provides the detail. The focus here is around the stroke pathway and managing pressures that we have, particularly with the staffing of this pathway, and ensuring we keep it safe and
And you might want to turn your video off. I think we're losing your dialogue a little bit.
Oh, sorry. I thought it was working so well. How's that?
That's better. Sorry, but that's better. Thank you.
No, that's all right.
Thanks, Joe.
I'm happy to be incognito, although I know it's not quite how we want to present ourselves. So, cool. I'm not sure what you've missed there, but just really by way of introduction then, this is about stroke, implementing a direct admission pathway through Cheltenham General, and developing a more resilient interim solution. This is a temporary solution that we have proposed. The one change that I wanted to just come on to is that in the paper we describe, I believe it's on page 2, actually it's on the second page of the text, so it's in section 4. We describe that the temporary service change will be implemented with week commencing the 10th of January, so i.e. from yesterday. Following further work at the hospital, there has been a decision taken to implement this actually from February, with other mitigations having been put in place for the rest of this month. So I'm sure Simon could provide a bit more detail on that if required. But our view is that we will still bring a further update in March, along with a wider update we're doing on stroke, to bring an integrated view of what we wish to do next, not least because the temporary service change that we also put in place around the Vale, which was increasing the stroke capacity at the Vale, is also due for review in March 2022. So we will bring a view of both this temporary change and the temporary change around the Vale in March. But I just wanted to stress that this paper is just about the location of services between Cheltenham General and Gloucester Royal. So at this point, we're not proposing any other changes to any part of the stroke service in our county. So as you say, people have had the paper. Hopefully that's not just too brief. And I'll stop there and just open it up to the floor for questions, if I may. Is that okay?
It's absolutely fine. Thank you.
Okay,
I
great.
see no hands going up. Oh, I do. Dilys. Dilys?
Yes,
Dilys?
I'm trying to unmute here. Yes, just a quickie, I hope. Now, I just want to make sure I'm understanding this right. That there will be a stroke direct admission pathway to Cheltenham General. So does that mean that people who've got stroke symptoms will be taken by ambulance into Cheltenham General rather than anywhere else? And I'm just wondering what will happen at night when the A&E is not sort of working at full strength. I wondered if you could tell me that.
No, I think both really good questions, and we had hoped to have some clinical input today, but just due to the pressures in the system, we've not been able to provide that today. So I'll hand over to Simon. He'll provide some information, but if necessary, we can come back with a bit more information if you don't feel that gives you the full info that you need. Is that okay? Simon, over to you.
Yeah, hi, morning everyone. So not all stroke symptoms, Dilys. So there's the paramedic team will have a conversation with our medical team at receiving unit at Cheltenham. And for those patients that meet the criteria for suspected stroke, then they would be routed into Cheltenham General, and all other patients would continue to go through Gloucester Royal. And that pathway would operate 24/7. So overnight, we would bring patients straight into our diagnostic area. So that you'd have a CT scan early on if you're a suspected stroke patient. So you'd come straight in to have your CT, and then a decision would be made then.
Okay, Dilys, that sounds a good answer. Thumbs up from
Thank you.
Dilys. Well done. Well done. Stephen Hurst. Stephen? Mute. Stephen, you're on mute still. Mute. Stephen?
Could I just ask Simon answer a question? Where would that triage be done, Simon? Would it be done in Cheltenham or Gloucester?
Simon's on mute now.
Did you mean with the paramedic, Stephen?
Yeah.
Yeah, so they do that over the phone. So we use a system called Synapsis, which GPs and other colleagues can use. So it's a telephone conversation based on a list of criteria.
Okay.
Thank you.
That sounds good. Okay, I see no other hands. Simon, Ellen, happy to accept the recommendation. Is that okay?
Thank you, Chair.
No, thank you. Thank you for keeping it succinct and easy to follow. So that takes us on to item 8. Again, another double act on the performance report. Who wishes to go first? Deborah, you need to leave shortly. So do you want to say a few words at the beginning?
Thank you, Andrew. I'm just putting my video on. I think you can see me there now. Fascinating meeting, I have to say. Even though I work around primary care, I've learned some things this morning about what our GPs and their practices do. So thank you to colleagues for that. In terms of what's going on in our hospitals at the moment, we are in a phase that I'll describe as a stable phase. So the numbers of patients in our hospitals with COVID has been plateaued for a number of days now. We always welcome those periods after an initial climb. We've got about 115 patients this morning with COVID. What's very positive is that we don't have any patients in our critical care unit who are actively being managed for COVID. And we know that as Omicron becomes the dominant variant affecting people right now, that they are more likely to be affected by milder symptoms, and in particular to be protected by the booster if they've had the opportunity to have that. So those that are in hospital, I describe it as a large number being in hospital with COVID rather than because of COVID. So these are patients that were coming in for other reasons, but upon testing at the point of admission or entry to ED, had a test and were found to have COVID. Many of those patients weren't aware themselves that they had COVID, which again just talks to the importance of us all continuing to test ourselves through lateral flow, etc., particularly if we do have any symptoms. So it's a challenging picture. However, Chair, we continue around COVID to have everything else going on at a level that is more redolent of the darkest and deepest winter months. So our hospitals are incredibly busy. Positively, we managed to step out of our internal incident mode that we had been in for around a week following the Christmas period. But our biggest risk, and it will be of no surprise to you, continues to be the fragility of staffing. We have staff that are off sick due to COVID. We've got staff who are isolating due to COVID, but we also have all the other things that affect staff in good times and bad. And as we've talked about today, we also have got more staff than is typical describing poor morale, reporting symptoms associated with anxiety and depression, which again is not different to what we're seeing in populations at large, but something that we're especially tuned into in terms of trying to support staff to stay well, to remain at work, and to support their colleagues, which is what the vast majority of them went to do. But it is tough, and the reason that our staffing remains amber rated as opposed to red or black is because of the sheer dedication and commitment of colleagues who have given up annual leave, who work on their days off, who work extended hours. But you will all know from your own lives and from conversations here that that isn't something that is sustainable for even the medium term. We will get through the next few weeks when I hope this peak, this current surge will have been and gone, but we will then need to have a whole country, let alone county conversation, won't we, about what does it mean to live with something that's probably going to be described as endemic rather than pandemic, something that we need to live alongside as best we can. So that's all I would say, Chair, and happy to take any questions.
Okay, thank you, Deborah. Any questions, Joe? Sorry, Deborah has to leave for a serious meeting. Thought that this isn't a serious meeting at 12 noon. So David Drew and Dilys Barrow, and then Stephen Hurst.
Deborah, I mean, the various charities I'm involved with, we're losing a lot of staff to agency at the moment. Is that happening with NHS staff as well?
We're not losing a lot of staff to agency. What we try and to do is use what we call our bank, which is rather than an external agency employing staff, that we give staff the opportunity to work flexibly on our bank. So, for example, if somebody says that they plan to leave their role because they can't work full time or they don't want to commit to the shifts or the hours, what we'll do is encourage them to register with our bank. We talk about it as flexible hours, and that's hours without the H. So flexibly hours is encouraging people to continue to work for the trust, but in a way that best suits their lifestyle. It is always a risk because we're also incentivising people to work on our bank. So we pay more than I think any other bank in the Southwest to attract staff because A, we value them, and B, we've got these staffing issues. And the risk there, David, as you're intimating, is that people step out of a substantive role into something that they consider to be more flexible and better paid. But as things stand, it's not a huge issue. We haven't got a huge migration from substantive employment to bank, but we do keep a careful eye on it.
Okay, you happy with that, David? Do you want to come back?
No, that's fine. That's good.
Okay. Okay, thank you. So Dilys over in Cheltenham.
Yes, thanks very much. Yes, thank you for the report. I was really pleased on the dashboard to see that some of the things were actually put down as green, which was good. I was sorry that there was still a lot of red, but it does sound as if you're sort of managing to cope with things at the moment. I'm just wondering, I've seen on television, they've had to call in military support in some hospitals. Have you, any worries about that sort of thing? That's one question. The other one was another thing I saw on television were reports about our eating disorder service. There was this, they were saying that ours was actually worst in the country. And
Can I just stop you on that one, and I can answer that point,
right.
because it's directed at another trust, and let Deborah answer your question, then we can take the others before she has to leave. Is that okay?
Okay, thank you.
Thank you, Chair, and no plans to embrace the military in Gloucestershire right now. As I said, our staffing levels, we rate them green, amber, red and black. You need to be approaching black to be considering deploying the military, and apart from a very small number of areas where on occasions we trip into red rated staffing, we're not close to that, Dilly, so no, I don't expect to see that. The one final comment I would just make, because it was an oversight in not raising it, Andrew, in my update, is that one of our biggest challenges and the thing that we spend most time working together on as system partners is the 200 plus patients that are in our hospital beds who are ready to go home, but for a variety of reasons we can't achieve that. And it's not an easy thing to say, is it? But hospitals are not good places generally for older, frail and vulnerable people, particularly once the balance of risk has changed and their acute condition has been dealt with. The best thing for those people is to be back at home or in the community in some other setting. So we're working really hard on that, but the pressures that you see that the media reports in relation to waits in our emergency department or ambulances queuing all emanate from the fact that the demand for beds exceeds the number that we've got available to us, and that's largely because of the large numbers of people that we're not able to discharge. And the reasons are multifactorial. There is no one thing. But as we've talked about before here, and you all know about, the fragility of social care in our county and nationally is a key concern for us all, and nobody more than Sarah Scott. And we're working together to try to deal with that. But again, it's a national issue, not just a Gloucestershire issue.
Okay. Deborah, thank you. And Dilys, hopefully that answers your questions. Stephen Andrews, you're next.
I think I've just had Deborah answer about 90% of my question. She must have seen my hand going up. But
I think she's very clever, very astute.
But just to follow on from that, perhaps, ideally, the ICS actually offers a way forward on trying to smooth out the whole of this system approach that's needed, of getting the right people referred to the right place, and the system ready, the next step in the system ready to accept them. And I just wondered whether either yourself or in fact even Dame Jill might be able to respond to how this is going to be taken forward as part of the ICS.
Well, I'll comment briefly, and as you say, Jill is also well placed. I guess, as Jill described, we've been on this journey to a formal entity of an ICS for nearly 2 years. April 19, was when we were in shadow, and 20 formally. So I would like to say that what's coming down the tracks, is the magic wand, is a panacea to these issues, but actually we have been working as if we were an ICS for a very long time. So there are always further improvements, further developments, but I wouldn't want to position the ICS as an answer to these long-standing and what feel at times quite intractable problems. It's not for the lack of joint working with colleagues in the local authority, with social care. They have been at the table, they have been valued and effective partners for a very long time. But let me, and Jill can comment on what the icing on the cake might be from her perspective that comes with being a fully formed ICS legal entity on the 1st of July.
Okay.
You might be on mute, Jill, if you're talking. I can't hear you. Maybe you've left the call.
Yeah,
I think she's there, but maybe she's having a bit of issue connecting, because I can see she's still on it. But
okay, I'm just conscious of Deborah Lee's time. So, Stephen, does that answer most of your question? Well, the 10%.
No, it does, but I think there'll still be that issue of integration and how the whole of system is looked at. It's still hanging out there as an unanswered question at the moment.
No, I think it's a question that we as HOSC have to address as well. So, Dilys, I take it you're you're okay. You still got your hand up. So, can I, while we're waiting for Jill, to invite Mark to say a few words to present the report? Is there anything you particularly wish to highlight, Mark?
Thank you. Yes, and just building on some of Deborah's comments, if I give a little more system context. So as Deborah said, obviously a lot of pressure continuing on the system. As a system, we're at what we term OPAL level 3. So that's the operational pressures escalation level. So we're at 3, which essentially means that the health and social care system is experiencing pressure, and that is impacting particularly on the flow of patients out of hospital, as Deborah has described. So that's the reason essentially we're sitting at level 3. That's pretty much the situation across the country at the moment. As you'll be aware from a lot of the national reporting, and indeed many other areas are in level 4, so at the next level up. I think just to give a little bit more information in terms of some of the other performance measures may be helpful for committee members. So as well as all the pressures on urgent and emergency care, just to update on some of the elective care, so the planned care indicators. So I think good to report that diagnostic performance continues to improve. As you'll see from the report, there's particular pressure within echocardiography, but we have some additional capacity coming on stream, which is making real inroads into reducing those wait times, which is positive. As you'll see from the report, again, in common with the rest of the country, we continue to be concerned about the size of the elective waiting list, and committee members know all the reasons why that built up during the early phases of the pandemic. But I think, again, positive to report that particularly Gloucestershire hospitals in a really good position relative to the rest of the southwest and the rest of the country, and particularly good progress in terms of bringing down the number of patients who are waiting the longest for elective treatments, as you'll see from the report. I think other things just to update members on, so cancer performance continues to be strong, particularly for the 2-week wait pathway, and obviously a very strong message that we're continuing to give to our population to continue to access services, and particularly important obviously for patients with potential cancer symptoms. 62-day performance, as you'll see from the report, is under pressure. That's particularly with some issues related to the patients who have a very complex diagnostic pathways, so need a series of diagnostic tests, often from a range of different parts of the cancer service. So a lot of focused efforts there. I think finally, Chair, just to say a word around mental health services, and I know GHC colleagues will want to respond on the question raised around eating disorder services, but I just reflect that the pressures across the system, obviously not just around physical health, but also around mental health. And you'll see within the report, we reference particularly increased demand upon mental health services, both for adults and children's and young people's services. So there has been a significant increase in referrals into those services. Again, in common with other parts of the country, but a real pressure point as well for colleagues within mental health services. Thank you, Chair.
Okay, thank you, Mark. Any questions to Mark on what he's spoken about so far? I will pick up, Dilys, the issue about eating disorders with hopefully some help from Paul Roberts. But I'm just looking at the little clock here on this laptop. We've got 2 more minutes with Deborah Lee before she leaves. And I think Andy Seymour, if he hasn't left, is maybe going to the same meeting. Any questions to either of them, please? So Stephen Hurst, sorry.
A really simple question. What is the primary difference between a pandemic and an endemic?
Who's want to take that one? And they've got 5 seconds to answer that question. Who's going to deal with that one?
I'm so pleased that the experts on the call. Sarah, over to you for the textbook definition.
Okay, cool. 5 seconds, Sarah.
So call that a hospital pass, Chair.
I'll accept it, Deb, don't worry. So a pandemic is basically an outbreak of a disease that has reached global proportions. It's huge. Right. It's larger than an epidemic. For something to become endemic, it means that it's in our communities, it's in our population, and it's not going anywhere. So these slightly different things. So we're probably at the point when COVID is becoming endemic. I think we're all accepting that perhaps it's not going to go away. We have to find a way to live with it. I think Omicron has has been a timely reminder that perhaps COVID has got a few more surprises for us yet. But I think for something to become endemic, like seasonal flu is endemic, we have, you know, a good vaccine program, we have treatments, we can predict it, we can model it, and we understand it. I think we're probably a little bit away from truly understanding COVID at the moment. So they are two slightly different things.
So geographic spread, which really determines whether it's one or the other.
To an extent, yes, because we could have a new pandemic tomorrow. I really hope we don't. But it could start off as an epidemic, for example, in parts of the UK, and then spread to become a global pandemic. It's about the scale of the spread of the disease. Something to become endemic, it's almost like a follow-on, if you like. It becomes something that we learn to live with, where it's embedded within our communities, and either we have good treatments or vaccination programs.
Sarah,
thank you very much.
It's really easy to follow explanation. 2 more seconds with we've got questions for Deborah Lee or Andy Seymour. If not, I'm going to count them out almost. I'm not going to count them out, but just very quickly, thank you for your courtesy and your patience in answering these questions and the work that goes into the reports. Against your background to the pandemic, endemic, or whatever it's called, thank you so much and for your good humour. Thank you. Okay. So I'll quickly pick up the issue of the eating disorders issue, Dilys. I think I must have been watching the same programme on Points West one evening last week. And so I saw that report. I obviously didn't know it was coming along. I didn't know the person who was interviewed. So I emailed Sarah Scott and Becky, I think it was, and said, who looks after this? They said it's commissioned by, I think, please correct me if I'm wrong, guys, it's commissioned by the CCG and delivered by the Health and Care Trust. At which point I then sent an email to Paul Roberts, who's on the call still, hopefully, and said, hey, Paul, just watch this piece on Points West. I don't know if it was just one-sided and a bit slanted. He told me that there were issues, Dilys, which the report addressed on Points West and which were being addressed. I then subsequently emailed Mary Hutton, the chief exec of the CCG, saying, please can we have the metrics on the eating disorders service shared with us at HOSC as part of your report? And I think that's been taken on board. So, Paul, I'm sure you've got lots more to add to that, but would you like to say a few words now on that Points West broadcast?
Yes, thanks, Chair. Happy to comment. And we were slightly taken by surprise by the broadcast ourselves because some questions about eating disorder performance have been asked several weeks later, and we didn't know they were going to broadcast it when they did, which was over the Christmas period, and we don't like to be caught off guard like that, quite honestly. But anyway, just to give you the background. So I mean, they opened the piece by saying we were the worst performing in the country, and I just want to be really clear what we're talking about here. The service has an extremely good reputation for the quality and diversity of the offer that it makes. It is one of the busiest services in the country, and one of the key problem that we're wrestling with at the moment is the level of demand. So there are two relevant facts here, I think. One is that if we look at the demand pattern on eating disorder, on our eating disorder, our specialist eating disorder service, it's the second highest level of demand in the country. So if you look at referrals into that specialist service per 100,000 population, it's sitting at somewhere near 200 per 100,000 population, when the national average is 60, and the average in the southwest is slightly lower than that. Now, that statistic, there are lots of complicated things that lie below that, and in what lies below that lie some of the solutions, probably, and I'll come back to that in a second. I think the other relevant statistic is if you look at the eating disorder services for people under 18, since the pandemic started, since the reporting year 2019-20, we've had an increase in referrals of 99%. So we've had a huge increase. That's been a national issue, to be fair, but we started from a very, very high baseline of referrals into the service. So as you can probably imagine, a service that gets a level of increased referral of that size you know, any service is going to really struggle with meeting that demand in a very, very quick time period. What is measured, so the measures that the BBC piece was referring to, there were basically two measures. One is the percentage of urgent referrals that are seen within 1 week, and the other measure is the percentage of routine referrals that are seen within 4 weeks. We have plans that are well developed, some of which are being rolled out now, which include increased staffing and bringing online some different pathways of service, which are already beginning to improve that position for people referred into the eating disorder service. One of the main issues, given the demand levels that I talked about earlier, is that many services around the country deal with routine eating disorder services through other routine core services, such as CAMS services if they're under 18, and using third sector partners to deliver quite a lot of the care for more routine eating disorder referrals. And that is not done to any great degree in Gloucestershire, and we really need to develop that service. Colleagues on the committee may recall that at the last meeting in November, there was a presentation from my colleagues on mental health services, and in that, something called the Community Mental Health Transformation Programme there was a brief discussion about that at the committee, and our eating disorder services are part of that programme. So that was briefly mentioned, I think, at the November meeting, and we're doing quite a big reinvention of the eating disorder services along the lines that I've just talked about. So I suppose the takeaway message is, yes, we are struggling with access times, but they are now improving. We're having a complete redesign of the pathway, including bringing in third sector partners to help us deal with more routine referrals. We've recruited well over the last few months, so we're beginning to make inroads. But I think what I can give assurances to the committee is that it's a very well regarded service. In fact, some of the people interviewed on that Points West point, I know in their unedited interviews, they were making really positive points as service user. There was a service user interviewed and a third sector partner, and they were saying how good they think the service is. So it's a good service, but obviously struggling at the moment with some of the access issues. I hope that helps.
Well, that's really, really helpful. Thank you so much. In terms of the metrics, Mark, I don't know if there's anything you want to add from this.
Yeah, I just want to reinforce what Paul has said. So a very highly respected specialist service, as Paul has described, which is responding to this enormous increase in demand. Councillor, we've done some analysis of the level of the increase in referrals, including breaking that down by district and ward level. I'm sure members of the committee might be interested in seeing that, so happy to share that after the meeting, if that's helpful.
Yeah, it's really good. Thank you. So, Mark, just a question from me, the one that I was addressing to Mary Hutton. Is it possible for us, for a while at least, to have some metrics on the service at HOSC? Is that possible?
Yes, I'm happy to do that. So Paul's mentioned some of those metrics, and we'll make sure going forward, Council, given the concerns HOSC are expressing, that we include those as part of the performance report. Absolutely, thank you.
That's really good. Paul, thank you. Paul and Mark, thank you so much for that. Dilys, I can't see you on my screen. Are you okay with that? Well done, I can now. Thank you.
Yes, thank you very much. I'm glad to hear that things are moving forward on this. Thank you.
You know, it is, I'm trying to choose my words carefully. It's disappointing, isn't it, when the media, whether they're the broadcast media or the written media, pick up a story several weeks after they sort of first raised it with you, and then do a live or pre-record and send that out without putting anybody else up. It's disappointing.
Chairman, I think that Nikki from Health Watch wanted to come in. Do you still want to come in, Nikki?
Sorry, Nikki. Apologies.
Hi, thank you. It was really around the cancer service information, so changing the subject slightly, if that's all right.
Sure.
I mean, the report highlights that there have been some delays in the service, but came to our attention just before Christmas that delays were actually for urgent cancer services were reaching months as far as tests and other investigations. One instance was brought to our attention. Somebody who was trying to access the service at the beginning of December was being told that tests wouldn't be available probably until February, March time, despite the fact that the consultant had identified the issue as urgent. Just to flag up, there seemed to be problems across the whole system because the patient couldn't access private intervention either, eventually did have to go outside the county, went to Birmingham, and was able to get intervention there. And I just wondered what's happening here. Was it I don't want to use the word blip, but was it a blip in the system? Obviously not for the patient. Is it something that is causing a real concern?
Was that, just to be very clear, Nikki, are we talking here about one individual case which was brought to your attention?
It was one individual, but on the during their investigations and they're trying to get access to treatment, they were hearing more and more stories that there weren't enough clinics, staff didn't quite know how to direct people. It did seem to be quite a significant problem, not just for one person. What I'm trying to do is, when the family are ready, I am trying to encourage them to bring the issue forward so that you can get more detail, but obviously it's not the right time for them at the moment.
No, sure. As a matter of interest, before somebody from the trust comments on that, did Healthwatch take those issues up back in December when they were brought to your attention?
We weren't aware of them at the time. This is stuff that's come to light quite recently.
Okay, cool. So is there anybody still here from the trust who can pick that up, please?
Chair, I'm happy to comment if that would be helpful. So thanks, Nikki, for bringing that to our attention. I'm happy to follow up that individual example if you want to get in touch with me afterwards. I suppose the key thing for us, the 2-week wait pathway, which is for the most urgent cancer cases. So that's the pathway I was reporting on, where we would continue to have really strong performance in Gloucestershire, and actually much stronger than other parts of the country. So that is a concern to hear that. But if you want to forward the information on to me, see with the suitable permissions from the patient, I'm happy to look into that further. Thank you.
Okay, thanks, Mark. Thanks, Nikki. Okay, any other questions, please, on the performance report? Helen.
Thank you, Chairman. I'm going back to the eating disorders. Now, under that heading, are we considering both anorexia and people who are overweight? Anybody know?
Yeah, I think I heard you okay. Paul, did you get that okay?
Yeah, I mean, it is more complicated than that, because there are separate obesity services as well. So we're not talking about obesity services, but there are psychologically related eating disorder services which involve overweight obesity as well. So there are some that do that. But there is obviously a specialist obesity service which is different and not run by us. Right,
but so it's mainly anorexia and allied illnesses.
Another psychologically based eating disorder services in our service. That's right. It's part of our mental health service in the trust.
Yes. Right.
Okay. Helen, you okay?
Thank you very much. Thank you.
Okay, that's fine. Good. Okay, so any other questions on item 8, the performance report? Anybody want to come in? Chip, who hasn't spoken, just slightly conscious of time, but we're doing okay. If not, can I thank everybody who's contributed towards this item on the agenda? Yep, she's still seeing her hands. And then move on to item 9. Ellen, again, you're back on, this time flying solo, I think, with your report.
Yes, I think it's just me this time. So I will see if I can put my video on, but if the sound quality goes off again, then just wave at me and I'll turn it off.
No, sure.
So this is, Chair, our standard ICS that we provide to you each month. So I will, and I think a number of the topics on here we've effectively already covered through our other updates, but I will just draw a few things to your attention. So the report starts by describing an update on the COVID position, and I think we've already discussed this. I'm not sure if we drew out the figure earlier of just over 1.3 million vaccinations now being delivered in our county, which is just a huge number. And I think you already very kindly gave the positive feedback to our practice and our providers. But it is a huge achievement that they have managed to deliver at that scale for our population. And Gloucestershire continues to be, if not the best in most measures, very close to the best in the country. And we actually heard recently that the Cotswolds is the highest vaccinated local district area in the whole country as well. So some real positives there for our system. We've provided an update in our Enabling Active Communities with a real programme with a real focus on health inequalities in the report, mentioning the Core 20+5 new approach to reducing health inequalities that NHS England have introduced across the country. And they identify for the Core 20 population key clinical areas to focus on for health inequalities. I am pleased to say that across each of these areas, these are not new areas for us. We were working on each of these already. So these are maternity, severe mental illness, chronic respiratory disease, early diagnosis of cancer, and hypertension case finding. And we have got work already across each of those 5 core areas for clinical priority. But we are looking again at our programmes and ensuring that we have got a very clear focus from a health inequalities perspective as set out in this approach. We've also given an update on our clinical programmes work with a focus on the journey to parenthood, personalised care planning work that we're doing, and a focus on children and young people's mental health. Now, we had a summit in October to really focus in on this area which is so important to our population, and in line with, and unfortunately, but incredibly challenged is the pressure on our services from the huge increases we've seen on referrals for children's mental health intervention, representing the very significant impact that the pandemic has had and the loss of schooling and so on and so forth. And we've got a very wide range of initiatives going on to support our young people. But we just wanted to share that in terms of the work that we're doing to really focus in following the summit to provide our young people with the care that they need and deserve. We've then shared with you some updates on our campaigns that we are out in the public domain with. We have our Stay Well This Winter campaign with top tips to help people with self-care and staying well through the winter period. We've got the Click or Call First campaign that we launched in December. We've also launched a wellbeing line for health and social care staff, and we had a big health and wellbeing week, and we've now got some of the outputs of that published, which is specifically around supporting people with mental health, learning disability, and other disabilities. I won't update on section 5 because we've covered that quite extensively already in our ICS development update. And so just to conclude, we're just providing this report for information and happy to take any questions on anything you'd like me to expand on further. Thank you, Chair. Oh, I think you're on mute.
You might be on mute, Andrew.
Well, yeah, thank you for that. So I don't apologise, Ellen, for again thanking you and everybody else who's contributed for your presentations, but also for the time that you take to put these reports together. And so when I say, let's take them as read, or almost just let's take them as read, it's because we have actually done that, and because you've taken so much trouble and time to put the reports together. So it's not just the time you guys put in at HOSC, it's the time, preparation time, getting the written amended and all the rest of it. Seriously, huge thanks for that. It makes our work so much easier. And I don't underestimate the time it takes all of you to put these reports together. They're not 5-minute pieces of work. David Drew.
Yeah, just a quick one, Ellen. I mean, anything on long COVID, numbers, demographic breakdown, societal implications? I mean, do we know enough yet? And where are we with Omicron? Because obviously, with a lot more people getting COVID, I mean, does this mean a steep rise in the number of people with long COVID?
It's a really interesting question. I don't know, Sarah might want to comment in a minute, and whether we know anything about Omicron and long COVID and whether we're seeing the same instance, because I think it's right to say we are seeing slightly less severe disease, but I don't feel well sighted myself on the long COVID issue. I mean, we do have data, we do have a long COVID service that we set up and are supporting people with. We do have numbers on that. I don't have them at my fingertips. I'm happy to provide them at another occasion if that would be helpful. But Sarah, I don't know if there's anything you want to comment.
I think it's too early to say. I think we haven't had Omicron for that long, really, to truly understand what the longer term implications of it are. So I think we're just waiting to understand more about it.
Okay. David, do you want to come back?
No, I think it's just something we need to monitor, because obviously, if the numbers do grow substantially, we've got to look at what service is available, because at the moment, until recently, we haven't known enough, and the friends of mine who've got it have just felt a bit left out, because it's not something that is necessary. I mean, people compare it to ME. I think it's even more unpredictable than ME. And that makes it quite a difficult condition to treat.
I agree. I mean, I know a few people as well, as I expect we all do, and it seems to be very up and down and quite unpredictable and wide-ranging in its presentation. It is certainly a complex thing. But yeah, we're happy to bring some figures back. That would be fine. Should we put that down? We can probably include that in the next ICS Leads report, so we'll just note that.
That's really helpful. Thanks, Helen. So moving on, Councillor Dillis.
Thank you. Thanks for your report. I'm particularly interested in children's mental health, and I noticed in the report your mention of On Your Mind website. I went to this website and I was really impressed. I'm just wondering how well this sort of thing is used, and whether children and people in general actually know about it. It wasn't something that I knew about, but it did look quite helpful. Thank you.
Yeah, and we have got, as well as the website, there's some apps and things that we've developed with our third sector partner, and they do seem to be well used by young people who quite appreciate some of the digital ways to get in touch with our services and to seek support. You can never over promote these things though, and we do work with our schools and so on to ensure that people have access to these. So yeah, I think just ensuring that we continue to share what's out there. It's great that you had a look at it. I think it is a really good resource. I don't know if anyone wants to add anything. Paul, if you want to add anything from your perspective.
Not a huge amount, other than just to, I suppose, make the point I made about eating disorders for people under 18. We've had a huge increase in demand for mental health services. So therefore, some of these upstream services where we're providing advice on mental health early on in a time when a child gets anxious are really, really important, because the referrals into specialist services have increased hugely during the pandemic, as we might expect. So these online-based services and the support we're putting into schools have just become even more important over the last year or so.
Okay, does anybody else wish to come in? Not sure I can see any hands. Oh, yeah, sorry, I missed you. Please go for it. Thank you.
Is that Helen? Are you coming in, Helen? I think you need to unmute. Are you all right there?
Yes, here. Sorry. Right. Hi. Yes. Hi. I'm Helen Fenton. I'm a councillor on Stroud District Council. I actually, in my professional life, I worked as a psychotherapist in private practice, and anecdotally, what I'm hearing is that young people are still waiting an enormously long length of time for even an assessment in children's mental health, which is not great. As a psychotherapist, there are things I don't do, like prescribing and diagnostics, and I really do need some of my clients to be seen through CAMS, the CAMS service. And when that doesn't happen in a timely way, that's incredibly difficult for the child, their family. And it places me in a difficult position as well, quite frankly, because these are clients at the beyond the capabilities that I have to help them with. So that's still concerning. Now, obviously, I don't know the overall statistics, but anecdotally, that is my experience. And then on long COVID, I also have a client with long COVID from the very first wave of the pandemic who is struggling. She's been referred by her GP to a long COVID service, but is struggling to get anything from that service that she feels is appropriate help. She's being sent kind of workbooks and advised to keep diaries of symptoms. And these are things that she simply doesn't have the capacity and the energy to complete at the moment. And so while we do have some services for long COVID in place, I'm not sure that they're always meeting the needs of the people, of the patients who are struggling to live with long COVID.
Okay, so two questions there, Helen.
Yeah. I mean, I will invite Paul to come in, particularly on the mental health waiting times, and he may wish to comment on long COVID as well. I mean, it's incredibly difficult. I think, as David spoke to the point earlier, there's such a broad church in terms of how people are presenting. So we do work with best practice and with the national team and so on, around how to, working on the service that we're developing. It's not just standing still. We're not complacent about that. It's obviously, I can't really comment on the individual case, but obviously happy, as the offer was made earlier, if there is any individual cases that people want to send for our attention, we can do that through the PALS service or providing that afterwards. But we do work with the evidence and the best practice about what to provide and our learning as we develop that. And I'm really sorry to hear about their experience. I think it is very tough in terms of the way it presents in so many different forms.
I appreciate that my anecdotal stories aren't necessarily representative of the bigger picture.
It's sad to hear, though, isn't it, when someone's struggling so much.
But Helen, are you aware that you can take these issues up through the PALS system? You're aware of that?
I am now, yeah.
Oh, it's all online, so also Becky can provide, we can provide, and we have that, and they are really supportive and they will help people navigate and so on. And that's where we can pick up those individual points.
It might be, no, sorry, Ellen. It might be worth us circulating around HOSC again what the PALS system does, who it's responsible for, too. And I was just asking Becky a couple of days ago some clarification on it, and just to encourage all of us to make more use of it. I think that's it certainly shouldn't be a mystery. So, Paul, do you want to pick up the other issues, please?
Just briefly, then, if I can just pick up both. So, I mean, I acknowledge, Helen, the issue about CAM services, and it's not a dissimilar story to the one I've talked about eating disorder service. In fact, while Ellen was talking, I've just called up the figures. So, on an average term time month prior to COVID, we were getting about 230 referrals a month into our specialist CAM services. Now that figure is close to 350. It's imagine a service that has to cope with that massive increase in very specialist demand. I take my hat off to the people who are having to deal with that, and we're doing all sorts of things to try and deal with that increased demand, because obviously the registered workforce is in short supply. So even if there's money there, you can't literally just go out and recruit huge increases in that stock, because the registered workforce doesn't exist. So we're doing a lot more clinical triage to try and make sure that we're treating the most urgent and complex patients. And obviously the CCG and the council have invested a lot in some of the services that we were talking about earlier, which are about trying to get much more upfront, earlier on treatment. We have advice lines for healthcare professionals. That might be something you personally may be interested in, because obviously we're not able to retain and provide a specialist service to everybody that might be able to have a service, etc. So there's a lot going on to try and deal with this increased demand, but I just think we all just need to appreciate that the last 2 years has just seen a really massive change in families and children and young people's experience of mental health. On the COVID, post-COVID or long COVID services, which we provide on behalf of the system, or we coordinate because there's input from various places. We all know that post-viral syndromes and a number of the syndromes associated with them have been quite problematic for the NHS to deal with comprehensively for a long time. And COVID is another example of that. Quite a lot of what we're doing is signposting, because actually what people with that syndrome need is some specialist service input. We're also been trying to work in a co-productive way with people that use the service to try and improve it as we go along. And I think, as Sarah said earlier, I know we're 18 months or so into people developing post-COVID symptoms, but it's quite early days for us to develop all of the responses that we need. But we carry on trying to design it to be as sensitive as possible to those people's needs. But any feedback is helpful. So really pleased to have that.
Thank you.
I'm just going to unmute myself. So that's a very positive note, Paul, there to almost end on, unless anybody has any other questions or comments, or is really keen to contribute, just conscious of time. But we take on this committee, actually, we take all the time we need. There's no cut-off point at all. But I see no hands. I see no hands at all. Nope. Okay, so Ellen, thanks again. Thanks, Paul. Moving on to item 10, which is the work plan. And the work plan, everybody, looks a little bit sparse. May onwards, I think. Just looking at my notes again. Is that right, Joe? It looks like a blank sheet of paper almost.
I think what we're doing is as we know, we've got the rather full meeting in March. I think, Chair, we're waiting to see what comes from that to fill in any gaps for May, July and September.
Sure. We've got, as I read it, Joe, we've got just a blank piece of paper for May, July and September.
We have, and I think it's a purposeful thing, because we were wanting to see if anything comes out of this meeting. I think the ICS, we were hopeful that we thought that things were going to start moving from April. That's now moving to July. So I think if there are any items that members want to suggest at this meeting for the future meetings, I don't know if Becky, if there's anything that you can think of that may be coming forward for the May, July or September meeting.
Just before we take Becky, I'm always very keen, and I did it when I chaired HOSC previously, to, as far as possible, try to ensure that our agendas are member-led, so that the ideas for scrutiny come from us as elected members, as well as receiving the really helpful and background reports from our colleagues in the health service. So I see a few hands going up there. First of all, Alan Priest, David Brown, and Helen again from Stride. Alan.
Thank you, Chairman, and thank you for chairing the meeting so impeccably. What I would suggest, I mentioned it earlier, is South Forest GP Health Provision, please, if that is put on the agenda.
So if you'd like to drop me an email, Chairman, and thanks for your kind words, unexpected, drop me an email and just in 2 or 3 sentences, that's all it takes, say what specifically you'd like us to look at in your locality. Does that make sense?
Chairman, and that will be done in the next day or so.
No, that's cool. And by the way, just a health warning here, there's no guarantee that we're going to buy all of these issues, okay? But just put them in the melting pot, and if some look really, really good, we're going to run with them. Is that okay? So next was David Brown.
Yes, thank you, Chair. I've got a possible future item. It's something I mentioned earlier in the meeting, the Dewey system, joining up your information. I think it would be key element of an efficient integrated health service in the future, although it's with us now. GPs have access to the Dewey system, and it enables patients' information to be shared across eventually all the health services, and it will bring great efficiencies, I believe. At the same time, we need to get patients on board with it because they are handing over their data, and they'll need some reassurance that it's going to be looked after. And so I think a PR message will need to go out.
So
yeah,
the same thing again to you, David. If you can just send me 2 or 3 lines.
Yeah, we'll do.
Look at it. Just very quickly, I signed up obviously to the COVID app, I get all that, and then also the NHS app, which where you can reorder standing prescriptions, which is really helpful. And also you can look at your notes going back almost to the day you were born. Boy, when I went back several decades looking at my medical notes, I thought, well, I forgot about that. Actually, I didn't realise this. And then it also says, what did GP thought of you? And that was quite fascinating too. Okay. Well, it's not that derogatory, but no, they were fascinating things. But one thing, talking about communications, when I was talking to somebody from our own hospitals trust, not that long ago, they were telling me, and I hope I didn't misunderstand this, that there was still no way of transferring information from one hospital outside of the trust to another electronically in certain circumstances. And I found that quite amazing. And I was giving the example of when I left the Bristol Royal Infirmary, I needed follow-up treatment at the chemotherapy guys in Cheltenham. And I said, the letter was sent to the wrong consultant, or a consultant who'd left years ago. Why didn't they do it on email? And I'm fairly sure I was told, we've got no way of getting emails across trusts. And that doesn't sound right, does it? Becky's obviously going to pick me up on that and tell me that I'm wrong. But that's how I understood it. But let's look at comms. And Helen in Stride, you put your hand up. Have you got an issue you'd like us to look at? No. No, maybe it's the side of your chair, which is the same colour as one of these yellow hands. I think it is. It's something behind you, which looks like you've got a hand up. Okay, anybody else? No. Okay, David, did you?
Chair, sorry, I got my hand up. Stephen Hurst and Jill Mosley.
Yeah, sorry, David. I'm just going to take David.
Yeah, just very quickly. I mean, I know we got children's weight coming up at the next meeting, but I think we should drill down on eating disorders. So this is a particular problematic area. So whether we have that separate to the March discussion.
Okay. So was it Dillis who said, Joe, in Cheltenham?
Jill Mosley and Stephen Hurst.
So Jill, go for it.
Thank you, Chair. This isn't an urgent one, but I think it would be useful for information. And it's an area I know I have some personal experience and know about, and that is ophthalmology services across Gloucestershire.
Okay. Send me just drop me an email explaining why. 2 or 3 sentences.
Thank you very much.
Okay. And Stephen Hurst. And can you just answer? Can you just carry on, but just hold on for 2 seconds while I answer the door to the postman?
I was wondering, looking at the joint meeting in March, whether we should carry some of the items through. For instance, health inequalities, to my mind, is an important matter which we just don't want to have a one shot at. It wants to be a regular report on health inequalities in the county.
Yeah, that's not a problem, Stephen. And I just want to say to members that some of the suggestions you're making at the moment, if they're not actual specific agenda items, they will be included in one of the information reports to the committee. So you will always get regular updates, and you may even get an update on the information that you've requested today as part of another report, maybe not a specific agenda item. So we would take, Andrew and I would take all your comments and your emails on board, and then we would decide, discuss about the best way of reporting back to the committee on your observations.
But Stephen, can you drop me a line with 2 or 3 sentences? And
Yes, fine, that's great. And secondly, about system flow, how easy, is it getting easier as the year goes on?
I've just got to answer the front door to the postman. Hold on. Well, carry on. I'll be 2 seconds.
Is it getting easier as the year goes along for people to be discharged from hospital into either care homes or back home, where another problem could occur care in the home?
Sarah, is Sarah there? Sarah, do you want to? Do we?
I don't want the answer now. I'm just saying.
No. Do we want an update as part of another report at another committee meeting?
We can provide an update. I think that but we are covering that at the Adult Social Care and Community Scrutiny Committee.
We are.
I think we'd have to think about whether we're going to scrutinise the issue twice. I think one of the aims of having the review of the winter plan on March's agenda was to look at the system flow across all the organisations, including adults, so we'd be part of that. And of course, any reports we send to Adult Social Care and Community Scrutiny are available to HOSC as well. So perhaps I can take that offline and to discuss with Joe and colleagues around how we best do that to prevent us doing it twice. Is that okay?
Yeah, I think we're fine. I think, Stephen, we have got something. We will be reporting on this at the Adult Social Care meet on the 25th of January, which HOSC members are always welcome to observe at. And then the 8th of March meeting, a joint meeting of the two committees, is really going to be an opportunity to discuss a lot of the issues that you've raised today. And just with the chairman's permission, just must remind everyone, it will be an extended meeting. It's going to be a longer than normal meeting, obviously, because of the amount of reports and information that will be presented to that meeting. There's likely to go on into the afternoon to 2 p.m. with a short break in the middle. So just to make members aware that the 8th of March meeting will be a joint meeting where some of your suggestions, Councillor Hurst, will be considered at that meeting.
So can I just make sure that everybody understands to send me 2 or 3 sentences with items for the agenda, because just looking at it, it's really stark. May, July, September, blank pieces of paper. It's not much more I can say on that. Just looking at the 8th of March meeting, Joe, and we always start at 10 o'clock. I mean, that's quite a leisurely time to start, and given that the meeting's likely to go on. I mean, if it's being held virtually, why couldn't we start earlier? Is that a problem?
No, not a problem. We need to sort of consult or just ask the question of our NHS colleagues and some of the professional people if they can do that.
Just very quickly, anybody, Paul Roberts, Mark, you guys, would you object if we started before 10 o'clock, 9:30, 9:15, 9 o'clock?
Personally, it's easier in some respects, actually, and allows us to, do other things later in the day if we manage to finish earlier.
Sure. So, I mean, a 9 o'clock start if it was virtual.
We could start at 9.
We could be over by 1:45.
I will send a notification, a message out to everyone, just to make sure that that's agreeable with everyone after the meeting.
Well, we seem to be getting thumbs up around the screen. Is that right? Okay. Well, I should have asked you, Joe, if 9 o'clock was okay for you. That's a bit discourteous of me. Sorry.
That's fine. I'm usually on the laptop about 7:30, so that's absolutely
fine. We know that.
Okay,
so I think that takes us to the end of the meeting, doesn't it? Is that the last item?
I think so.
Just before we all...
Councillor Stephen Andrews would like to come in, I think.
It was just really a question, because we've got reducing health inequalities. Sorry, I missed that when it might be rescheduled, given that the ICS is now due to be July.
So,
well, under possible future items, there is reducing health inequalities, date post April 2022.
Yeah, we can have a look at that one, Stephen. It's on the possible future items on the page after the monthly meetings there. Are you wanting to think about a suggestion of when you'd like that, Stephen? Or I mean, it really does. It is ongoing, really, isn't it?
It sort of is, and I just wonder what might be formally put in that place, because presumably we're not going to delay looking at that until July and later.
With the chairman's permission, I think we'll discuss this after the meeting with the chairman and see if we can slot that in with the other items.
So I'm just confused, just very quickly chipping in. Is reducing health inequalities an issue for HOSC? I thought that was for Stephen Hurst's committee.
Yes, you're right there, Andrew, and it's down for the joint meeting on the 15th of March.
Okay, Sarah Scott, you're going to introduce some sanity here.
So I think inequalities is a really broad agenda. Obviously, I'm the system lead for inequalities, so that's why it sits with me in the Adult Social Care and Communities Scrutiny Committee. But the NHS, the Integrated Care System, does have some very specific asks of it in terms of inequalities, which is why we thought it would be really helpful to bring that to the joint committee. The issue is, I think, there's an awful lot of business where the two committees overlap, which is why there's a lot in for March.
No, that's fine.
Yeah.
So I think with the 9 a.m. start, that's going to be fine, Sarah. Thank you for that. Okay, I'm really keen to start to wrap up. Helen, unless it's really desperate.
Thank you, Chairman. Just to add, I will be in touch with Alan Priest, because I'm anxious about health services in the south of the county, my ward, in other words. Because
okay. Now, Helen, so happy to.
I finish. When we're talking about GPs, a lot of my residents in my ward, their GPs are actually Welsh GPs.
No, okay.
The surgeries are in Chepstow.
No, okay, I get that.
When we're talking about consultation and advice to GPs and integrated care and all the rest of it, I'm wondering how we can make sure that the residents of my ward are getting the same care, because their GPs are Welsh.
Helen, I'm sure Alan's happy to work with you on that and merge that with the work that he's suggesting. You okay with that, Alan?
Absolutely, Chairman. Absolutely, Ellen. I'll be in touch, and no problem.
So, Helen, yeah, so Patrick's going to be in touch with Patrick. That's somebody else. Who's Patrick Molyneux? That's another story. So moving on. So I just want to thank everybody for their courtesy. Keep using that word, courtesy and good humour. And also the questions members you've asked. We'll try and summarise some of the points that have been raised so we can circulate them around the committee. One thing I'm keen to do is pick up all the various apps we've heard about, the websites we've heard about that we ought to be sharing, we should be sharing with our colleagues and the people we represent. I'll try and get that work done. I'll do it myself over the next few days, and then we'll be in touch. But don't forget, you don't have to wait for HOSC to raise issues. You can either raise them through the pals or raise them through Joe or myself or Becky. So with that, I was going to wish you a happy Easter, but that's pretty premature, isn't it? So I think I'll just say thank you very much. Enjoy your lunch. Safe journeys. Well, no need to safe journeys home, so I'm going to quickly cut off and get out of here and get my lunch. Okay. Thanks, everybody. Thanks for your good
Thank you, Chair. Thank you.
Thank you for helping me.
Bye, colleagues.
Thank you so much. Thank you. Bye.